For my
Okay, so good evening, everybody. I extend a hearty welcome to all of you on this unique SAFOG-FOGSI-ISAR webinar. Thanks to Dr. Gaurav for hosting this and coming up with this brilliant idea of the endoscopy webinar, which is very unique and includes a very vast and comprehensive topics. So this is the schedule for today evening, and I take honor in inviting Dr. Naren Malhotra sir as a guest of honor for our today's webinar, and subsequently we are hoping that Dr. Bhaskar Pal sir will be joining soon. So thanks to Dr. Apurv Kumar Datta and for being part of this from the STI and chairperson of Sexual Health and STI Committee. Thank you, Dr. Supriya Jaiswal ma'am, chairperson of Adolescent Health Committee. Thank you, Dr. Gaurav Desai, for hosting this webinar. I would like to invite Dr. Gaurav Desai to say a few words on this webinar.
Yeah, thanks, Aarti, for all your efforts. First of all, I think this webinar wouldn't have been possible without you. I'd like to, of course, acknowledge a host of people. I think first I'd like to have a short introduction. Can I share my screen? Okay, so, as Aarti mentioned, this is actually, can you hear me?
Yeah, Gaurav, you're audible. Yeah, and visible also.
So, as we discussed earlier, this actual webinar is actually bringing together so many individuals and connecting these committees, connecting societies. So I've actually brought in quite a few. This link has gone to a number of individuals around the world. And this actually is, the thinking was to actually bring together a number of people. So as you all might know, the pelvic infections, sexually transmitted diseases, it actually still plays a very vital role. This is not just previously, even now, a number of women are actually suffering. There's a lot of morbidity with pelvic infections, pelvic inflammatory disease, also sexually transmitted diseases. And, endoscopy has a connect with this. One of my first cases actually was, unfortunately, a 27-year-old girl was transferred from the interior of Maharashtra to my institute with severe disuse, had severe morbidity, was intubated, and we actually had to evacuate a severe pulmonary pelvic infection. So as you can see here, this was the imaging that we got. And of course, once we opened up, me and the surgeon, we found a severe pelvic infection, a perforated uterus. And unfortunately, this patient couldn't survive. So that actually stuck in my head. And I said, apart from all these conditions, we are actually dealing with a lot of problems as far as pelvic infection goes. So even in cases of where we are dealing with endoscopy, we have host of various pulmonary infections, not just typical bacterial, but also atypical infections which we are dealing with. So just for instance, atypical mycobacteria, on hysteroscopy, endometritis, like, for instance, Dr. Amogh Chimote now will be discussing about this and what the fertility implications are. Another very old endoscopy case which I did was of post-tubal ligation, having a large cyst like this with, who was febrile. So we had to evacuate these cysts. So pelvic infections are still here. They, of course, in our endoscopy lives today. The next is, of course, adolescents. I'd like to acknowledge Supriya Jaiswal, madam. Adolescence is that age group where you sort of all the results of development, the first 10, 12 years, actually one actually sees a result. And of course, we have number of problems that can come up in adolescence. One of them is, of course, developmental issues, which actually is not highlighted upon a lot in all these conferences. So, developmental issues which actually come about or come to light when these girls actually start menstruating, and it actually causes severe morbidity. If anyone has seen any of these girls, these adolescents, they are suffering tremendously. And once you know the correct management and the correct surgical management to this, there is a huge symptom relief. So, this has to be highlighted. One of the presenters, Surakshit, I've, specifically brought in because he does these type of surgeries. So, common anatomical problems include hematocolpos from an imperforate hymen. You could have an obstructed vaginal septum. So, but there are, of course, those with cervical agenesis also, which are there, quite rare, but it is an entity. And endoscopy plays a role in some of these developmental issues. So the next, of course, is adolescent endometriosis. We all discuss endometriosis in women who are 30, 40 years and even postmenopausal. But not much is actually done in the adolescent age group, because adolescent age group has a very long runway. They are actually dealing with many, many years of their life. So if it is correctly managed at the first go, the benefits are tremendous. So I've asked Dr. Smeet Patel, who, of course, at his center, they do quite a bit of this. So, just short data on endometriosis in this age group, 70 to 73% apparently of adolescents with pelvic pain that are almost unresponsive to medical therapy are found to have endometriosis. And so it's fairly high. It is not, I'm sure it is underdiagnosed. We are looking at it more and more. There is, of course, an entity called juvenile cystic adenomyosis, which occurs. These are severe pain, severe, dysmenorrhea, which occurs. So this actually can be treated. I'll let the expert speakers deal with that. We have also speakers like Munjal Pandya and Santwan, who have brought in because they are very good at what they are going to speak about. So they will, of course, enlighten us. I'd like to, of course, acknowledge Dr. Bhaskar Pal sir, who is the FOGSI representative to SAFOG, the Asha Bakshi madam, the honorary secretary of ISAR, Dr. Amit Patki also sent his regards. They are the chief guests of today evening. Of course, the guest of honor is none other than Narendra Malhotra sir. He is probably a celebrity as far as I'm concerned. He's a director of international relations of SAFOG, and his work across many years has really speaks for itself. Dr. Jaideep Tang sir and Dr. Madhuri Patel madam also send their regards. I'd like to thank Dr. Apurva Datta, the chairman of the STI committee of FOGSI, as well as Dr. Supriya Jaiswal madam, who is the adolescent health committee chairman, and of course Aarti. So this is a lineup of the number of speakers and the really depth and spectrum of talks that we are going to witness today. I hope that the viewers will enjoy this array of knowledge that they will get, and the stage is yours for everyone. Okay, thank you.
Thank you, Dr. Gaurav Patel. That was quite a well-informed introduction, and it was very touching to know that it was why this topic is so close to your heart. And now, may I share my screen? And I would like to invite Dr. Narendra Malhotra sir, somebody who needs no introduction and words fall short for introducing sir. Sir is the current director of ART Rainbow IVF Agra, and he's also the managing director of Global Rainbow Healthcare. And he has many accolades to his name. If I go on listing, I think I'll take more than 3 hours to list sir's accolades. Please welcome sir.
Thank you. Thank you.
Sir has been the guiding light for all us youngsters. You know, he has all those Yuva groups on WhatsApp where he keeps motivating us all the time. Thank you, sir, for all your motivation and So let us, without wasting much time, can we start with our first topic, that is safety at laparoscopy entry. So for that, I would like to invite our chairpersons for this topic, that is Dr. Ritika Agarwal. Are you here, ma'am? Dr. Ritika, ma'am?
Yeah, just introduce and move on.
Dr. Munjal Pandya will be taking this topic on safety at laparoscopy entry, and I would like to invite Dr. Ritika Agarwal as the chairperson for this talk. She is the current associate professor at Venkateshwar Institute of Medical Sciences, Gajraula. She has done her fellowship in reproductive medicine from Mumbai and holds a diploma in ultrasound from Jefferson University. She's a secretary of the Moradabad Obstetric and Gynaecology Society and holds 11-year experience and has keen interest in IVF and infertility. Next, the other chairperson for this session is Dr. V. Radhalakshmi. She's the current secretary of Kurnool Obs and Gynae Society and is a professor in Obs and Gynae department of Santiram Medical College, Nandyal. She holds a key position in several professional organizations, including General Secretary of FOGSI of the Kurnool Society, and she's the zonal CME coordinator for Zone 6 and other things. May I welcome both Dr. Radhalakshmi and Dr. Ritika to kindly chair this session by Dr. Munjal Pandya.
Good evening. Good evening, Aarti.
Good evening.
I'm here.
I'm stopping my...
Yeah, let Munjal share his screen.
Yes, sir. Okay, I'll do so. I hope it is visible.
Yeah, all
okay, thank you. Thank you so much, Gaurav sir, for giving me this opportunity. This is actually a basic topic which I would try to summarize in next 15 minutes. To be honest, in this era of endoscopy, we have seen a lot of with regards to advancement in technology and laparoscopy in these days and difficult cases. But I have chosen this particular topic because these are the initial first steps towards endoscopy, which can never be ignored with regards to when you actually start learning endoscopy. So yes, to begin with, there are safety measures, which with advancement of technology, we now have very improved versions of endoscopy instruments with regards to a lot of things which reduce and has significantly reduced the complication rate. There are various methods with regards to starting or entry of endoscopy. There are various methods and routes and modalities as well. The patient need to be selected properly to avoid any kind of mishap which might happen with endoscopy. So as to, not to receive blame on the endoscopy surgery itself. Proper patient examination is of utmost importance. I mean, obviously, with regards to endometriosis, we do all kind of workup, but then there are times where people do forget to do poor rectal examination, which is of great significance with regards to ruling out or even to check the mobility of uterus and rectovaginal endometriosis. Selection of appropriate technique according to the patient as well as surgeon's skill. This is very, very important. If I'm not very much comfortable with harmonic, I would actually try to avoid it. Till I get trained properly in that particular segment. So everybody needs to know the limitations and everybody needs to know where do they actually need proper training for. Jumping onto something just because somebody else is doing is going to actually land you in a huge trap. But over and above that, it will actually harm patients. So we need to avoid that, this craving of doing something which others do. We need to get properly trained. We need to actually know our own limitations and our own skill, and then would go for surgery or endoscopy or route of surgery. So what are the likely complications with regards to entry of endoscopy or entry of varus needle or trocar? So majorly, we encounter bowel injuries much more than vascular injuries. Now, with regards to bowel injuries, they are diagnosed a little late, and that might end up in peritonitis and might even lead to mortality. But while vascular injuries are more common with regards to laparoscopy on entry of varus needle or trocar because of proximity of vessels which are retroperitoneal with abdominal wall when the patient is in supine position. So the vascular injuries are diagnosed immediately and can be actually rectified. But in case of bowel injuries, they are usually diagnosed late. And as they say that bowel injuries, if ever happens and are ignored, are most of the times due to entry site rather than the proper surgical steps. So what are the steps with regards to steps of entry? So when we start with Varis needle. Now, this is very, very important because Varis needle is something which has a body, and we need to actually catch it from the body which is closer to the valve, because it has a spring action. Whenever we want to use Varis needle, we can actually, or we have to actually push the needle against dorsum of the hand so as to check the spring action. If that spring action is not functional, there is no advantage of it being or having blunt tip while entering the rectus sheath or peritoneum. So definitely that spring action needs to be checked before actually going for the its insertion. With regards to valve, there are people who would actually keep it closed so as to check it intraperitoneal position after its entry. And there are people who would keep it open as well. So depending on the surgeon's comfort zone, it can be kept open or closed while making that particular entry. So it has spring action, it has blunt tip, which would actually avoid injury to the bowels or even other structures which might be there in the way. We need to lift the abdominal wall so as to increase the distance between abdominal wall and the retroperitoneal structure, or majorly the vascular structures. And so as to make that distance approximately, to lift it, we can lift it according to the, the wall or laxity of the wall from 0.1 to 2.5 centimeter. Now it has to be inserted according to the position of the patient, which is usually or most of the times or ideally has to be kept as supine position. And then the angle can vary according to the obesity of the patient. If the patient is lean and thin, we would keep it more, angulated. With regards to horizontal surface, we would say that approximately 30 degree. If the patient is obese, we can actually go for more steeper angle that might be up to 90 degree. We would see in the later figures. So the angle can be changed according to the obesity of the patient, because the distance between umbilicus and the bifurcation of aorta will have a say in entry of that Varis needle. And as they say that about 1/3 to half of the major complications usually at the time of entry occurs due to Varis needle rather than the trocar entry. So this is a rough figure which would explain the position of umbilicus with regards to bifurcation of aorta. In normal lean and thin patient, umbilicus demarcates or would denote the bifurcation of aorta. As the weight increases, as the obesity increases, the distance between umbilicus and bifurcation aorta will be increased, which is up to 2.9 to 3 centimeter. Now, this will work in advantage of on our side, because we can actually use more steeper or 90 degree angle for entry of Varis needle or even for trocar, as the thickness of abdominal wall will be much more. And if we keep it more angulated, there are times that Varis needle may not even get into the intraperitoneal zone. So obesity of the patient needs to be kept in mind while deciding the angle of Varis needle and even of trocar. So there are several steps which would confirm the intraperitoneal entry or intraperitoneal position of the Varis needle. One is manometer can be kept closed when you actually enter the Varis needle into the intraperitoneal segment. The insufflation unit needs to be connected, and when you switch on the pressure segment, it would show the negative pressure of the intraperitoneal segment when you actually switch on the valve. Now that is one test which would say that the Varis needle is in intraperitoneal position. The other test is valve is kept closed and the abdominal wall is to be lifted. And when you open the valve, you actually hear the hissing sound of negative suction of negative intraperitoneal pressure. Third one is aspiration test. You have a pre-filled syringe, which is partly filled with the saline. And now you attach it with the Varis needle. You open the valve of Varis needle. You aspirate the content. If there is something like urine or even bowel contents, you actually remove the needle and proceed further for repair of particular segment. If the blood comes in that particular aspiration, the needle must be kept in its own place and laparotomy should be proceeded, as it might indicate possibility of vascular injury. So obviously with advancement of laparoscopy, again, there are various ways of dealing it with laparoscopy, way as well, route as well. But if there is no material on aspiration, 5 ml saline is injected, and if nothing comes out, then it can be said that the Varis needle is placed intraperitoneally. One more method to know is hanging drop method. You put a drop of saline and you lift the abdominal wall. If that drop gets sucked into the intraperitoneal segment, it is said to be properly positioned. So these are the 4 segments which would actually confirm the position of Varis needle intraperitoneally. Now, there is one study which actually concluded that none of them might even be confirmatory of Varis needle position. So obviously, one more thing beyond that is connection of insufflation unit with the Varis needle. And if the pressure is said to be less than 8 mm of Hg, again, it would stamp the position of Varis needle to be intraperitoneal. Do not move needle or do not waggle it down when you confirm the position of varus needle inside peritoneum. As they say, one of the studies would suggest that more number of attempts actually increase more complication rates, and lesser number, that is like if the varus needle is inserted in the first attempt, the complication rate was minimum. We know the Palmer point, which is 2.3 centimeter, at least 3 centimeter on the mid-clavicular line, 3 centimeter below or inferior to the subcostal angle. That is a point which is something which can be used as primary point of entry for the patients who had history of laparotomy, who might have adhesions in the region of umbilicus. And that is where the Palmer point will be of great help as the primary insertion or primary trocar entry point. Other less common entry sites I have not used personally are entry through cul-de-sac, which would actually lead to transuterine or trans-cul-de-sac position. And then you can achieve the pneumoperitoneum specifically in patients having morbid obesity. So how do we need to keep the intraperitoneal pressure? So once you confirm the position of varus needle to be intrauterine, which will show the pressure to be at least 5 to 8 millimeter of mercury, you can increase the pressure up to 12 to 15 millimeter of mercury, and then main trocar of 10 mm can be inserted blindly after lifting abdominal wall properly. Now, there are times where people would suggest lifting the abdominal wall on both the sides of midline. Now, that would create tenting in the midline, which is not going to be of benefit with regards to trocar entry. So lifting the abdominal wall between the umbilicus and pubic symphysis in the midline will be of great help with regards to trocar entry. Now, there is one more segment. If you actually increase this particular pressure to 20 to 25 millimeter of mercury, it actually increases the distance between abdominal wall and retroperitoneal vascular structures. That would create a splinting effect, which actually increases the safety while you insert the trocar. In the figure, I have tried to show various types of conventional trocars with the cannula. So the position of patient, as I said, need to be flat on table. Triangular position, which is previously said to be of great advantage with regards to pulling down the bowels towards the diaphragm, is now no more recommended since many years because of this possibility that abdominal wall will come closer to the retroperitoneal vascular structures, and that would again increase chances of vascular injuries. So flat position is to be maintained with regards to trocar entry. One more technique for safer entry is Hessen's technique. Now, this is known as open technique as well. In here, we actually put a mini incision, which extends up to rectus sheath as well. We take stitches on both the sides of the particular incision. We'll lift both the threads, and then we actually insert our finger to confirm the intraperitoneal placement, and then we insert the trocar. Both the threads are kept as it is after trocar entry, and once the surgery is done, they can be closed so as to avoid future hernia or potential possibilities of hernia from that particular side. So rectus sheath or the whole abdominal wall will be sutured very easily after you finish off the surgery. The only limitation is it takes longer time for trocar entry, plus it might actually be responsible for gas leakage from the surrounding area of trocar because if you actually have extended incision or have put bigger or larger incision as compared to the trocar diameter. Other modalities of trocar are like direct trocar entry. There are people who are used to it, and obviously the virgin abdomen is ideal condition with regards to direct trocar entry. Disposable shielded trocars are there, where actually when the resistance is encountered, the tip will come out. Rest of the time, there will be protective sheath, which will not injure the surrounding structure. And one more advancement is optical trocar. There are various names of it, like endotip or visitip. Now, this trocars, whenever you are entering that particular abdominal wall, it is constantly under vision. So all the layers of abdomen can be seen while you enter the through the abdominal wall. And when you are inside the peritoneum, then you are sure that you have not injured any particular organ, and you have safely entered the intraperitoneal segment. So optical trocars are again one new modality which has been in use since long. Now, special case scenarios. What if the patient is obese? As we have seen, that obesity has been on being advantageous with regards to the trocar entry. We can actually go 90 degrees because the distance between umbilicus and the bifurcation of aorta will be approximately 2.9 to 3 centimeter. So there are no chances that we would injure any kind of vessels with regards to its entry. Optical trocar system is said to be ideal, again, to be on the safer side because the abdominal wall layers will be thicker, and we might actually have to push the trocar a little more. And in that particular scenario, the excess force can be of detrimental, creating any kind of injury. So open Hassan's technique is one more possibility if the optical trocar system is not available. And entry through umbilicus is said to be ideal because the abdominal wall layer is thinner or the thinnest in that particular segment. So in case of obesity, the direction of the trocar entry needs to be kept in mind. The various technologies or types of trocars which are available need to be kept in mind. And at the same time, umbilicus would be the ideal place with regards to the primary trocar entry. Now, what if there are previous surgery? As we know, the adhesions are something which are created to derive oxygenation, and that particular oxygenation can be derived by attaching to some other segment of the body which has the vascular supply. So it is not exactly like wherever you put an incision, the adhesion will develop on that particular site only. It can be extended up to any area or segment around that particular operative area with regards to abdominal wall, which will help that particular ischemic segment which is created to derive oxygen out of it. So adhesions are formed in case of previous surgery. In that particular case, as Gaurav also suggested, there are times like MRI and sonography would be of great help to diagnose those adhesions. And in midline surgery, they say the adhesion creation possibility is much more as compared to the financial incision. And Palmer point is said to be the ideal way for primary trocar entry. Now, if you want to avoid gastrointestinal complications in case of major or supramajor surgery, we need to actually prepare bowels properly. We need to do per vaginum and per rectal examination properly. Ultrasonography and other imaging studies, if required, need to be done. And RT incision, that is right tube insertion, needs to be done so as to avoid, so as to decompress the stomach and avoid injury to inflated stomach. Now, this is one more point, which is Jain point, which was published in 2016. Now, this is a point where the entry point or the primary entry point is at the level of umbilicus, as shown in the figure, and the vertical line is drawn 2.5 centimeter medial to anterior superior iliac spine. Now, this particular point would serve as primary entry point in case of previous surgeries. Now, how is it different from Palmer's point, and how it is more advantageous? In case of Palmer point, we have safe access. We are sure that there are no more adhesions on that particular segment. But there are times where if the patient is obese or patient is taller, that particular port will be of no use with regards to vault closure. At times, we would find difficulty in reaching up to the vault after finishing up total laparoscopic hysterectomy. While in case of Jain point, we will be able to reach that particular vault because it is at the level of umbilicus and it is little lower. And the main port can be inserted through that particular Jain point. Plus one more advantage of this particular segment is, in case of previous gastric surgery or splenic surgery, Palmer point is something which must not be used, while Jain point can be used because it will suggest a raw area. As shown in the figure, that particular segment or that particular point will be unaffected with the history of splenic or gastric surgeries. So it is very, very safe as compared to the Palmer point. And you can compare the distance between Palmer point and Jain point. In case of Palmer point, again, the instrumentation will be a difficult task. One more point or newer point is a Lee-Young point. Now, this is a central point between xiphisternum in the midline, between xiphisternum and umbilicus, and primary port or Verey's needle can be inserted through that to create pneumoperitoneum. And then again, trocar can be inserted as and when you can find properly, without possibility of any further injury. So this is a comparison of LH point, umbilicus is shown, Palmer point, and exactly on the side of or at the level of umbilicus, we can draw a J point as well, which is quite accessible with regards to instrumentation. So to summarize, I would say that proper patient examination is of utmost significance rather than getting influenced by hi-fi surgeries, which we usually see. Preoperative preparation of the patient with regards to all the imaging modalities as well as the bowel preparation is of great significance. Positioning of patient is usually flat position. Trendelenburg position is to be avoided. An approach for Verey's and primary trocar need to be evaluated even preoperatively and on table as well. And eternal vigilance with regards to all the parameters or the manometry and all the pressure. As we say that there are times when you actually increase the pressure of intraperitoneal pressure up to 20 to 25 millimeter of mercury, anesthetist would be of concern, but then it is shown that such a pressure will create no cardiopulmonary compromise and is safe with regards to primary trocar or even secondary trocar entry. So this is I have to say with regards to laparoscopy entry and its safety measures. Thank you.
Thank you, Dr. Munjal Pandya. May I invite Dr. Narendra Malhotra sir to kindly give his valuable comments for this.
Narendra sir, are you there?
Yeah, I'm here, right here.
So please say a
So,
few words.
yeah, thank you for inviting me here as the guest of honor for this very, very interesting webinar on endoscopy. And this is what is required, especially when youngsters today, after MD and MS passing out, just want to do a laparoscopic surgery and want to do all the other things except obstetrics. So you have to get yourself trained and learn yourself. Now, when we go for training, a lot of people say, how much hands-on will you give? See, hands-on is what you have to do yourself. When you observe people like Munjal and the others operate, Prakash Trivedi, Prashant Mangeshkar, Rakesh Sinha, we just stood in the OTs and watched them operate. And when you watch them operate, that is when you learn much more than actually going in and holding the scissors to cut something or cauterizing something. So my advice to all the youngsters who are there, please observe and watch the experts before you actually try to do. The entry of the trocar is the most important thing in laparoscopy, which I believe. As soon as you know how to enter the abdomen, you can do practically everything. The rest ones are all what you learn. So I congratulate Munjal for very beautifully, illustratively telling us all about how and what to do and what care should be taken at the trocar entry so we don't injure blood vessels, we don't go into the bowel, and we are happy to make a pneumoperitoneum so that our surgeries can be there. Congratulations, Gaurav, SAFOG-ISAR and FOGSI combined, which is again needed, that all organizations should combine and do webinars like this and spread it all over. Congratulations for all of you for organizing this webinar. Thank you for inviting me here.
Thank you, sir.
Thank you, Narendra sir. Thank you, sir.
Thank you, sir. May I request the chairpersons to kindly give their valuable comments?
Congratulations, Munjal. It is a very nice lecture, and so many points are completed in this 10 to 15 minutes talk. And most of the laparoscopy will be done, half of the laparoscopy will be done once you enter into the abdomen. That is more important. So you explained in a very great way about how the points of the entry of the laparoscopy. Thank you very much.
Thank you, ma'am. Thank you so much. Thank you, Gaurav sir.
Welcome. Aarti will move.
Moving ahead to the second talk, I am sharing my screen here, and may I invite Dr. Amogh Chimote sir to kindly take his talk. Before that, I would like to welcome our chairpersons for this second session, Dr. Archana Kumari and Dr. Apurv Datta. I'll be sharing their CV slides. So the second talk is by Dr. Amogh Chimote on hysteroscopy in endometritis and fertility implications. Hysteroscopy per se is very close to my heart. And I would like to invite Dr. Archana Kumari ma'am. She's the secretary of Ranchi Obs and Gynae Society, founder secretary of IFS Jharkhand chapter, and is the elect executive member of National ISOPAR for 24 to 26. She's been the vice president of ISOPAR Ranchi chapter in 23 to 25 and is was secretary from 2020 to 23. May I welcome you, ma'am? And ma'am has many accolades to her name, and she has multiple publications in various national and international journals, and is also an examiner for UGs and PGs. She's also the recipient of MS Signature Award in 21 and also the FOGSI-ISAR Award in 2022, among other awards. Next, I would like to invite Dr. Apurv Kumar Datta. He is the current chairperson of Sexual Health and STI Committee and a dear friend of mine. He's also the national coordinator for Sexual Medical Committee of FOGSI. He's a winner to multiple awards which have been listed here, and I will not name each one of them. Currently, he's
Thank you so much, Aarti.
Young Gynecologist Award, and I keep asking him for the secrets of receiving all these awards one after the other. He is also faculty at multiple conferences and has published various publications to his name. Hi, Apurva. So please kindly introduce Dr. Amogh Chimote.
Archana ma'am?
Yeah.
Yeah.
And-
Yeah, please, ma'am, please
Okay.
go ahead, ma'am. Yeah.
Good evening, everyone. First of all, I must thank Dr. Gaurav Desai for giving me this opportunity to be part of this webinar. And of course, my thanks to Dr. Purva, Dr. Supriya also. And my regards to Dr. Naril Malhotra, sir. It is indeed an honor to be a part of this interesting webinar. And let me introduce the speaker. He has been the medical director in Vasundhara Fertility Center, Nagpur, and he's a profoundly skilled gynec endoscopic surgeon and consultant OBGYN. And he has been the joint organizing secretary of FertiQuest Nagpur. He's been member of ISAR, and he has got so many publications and he has got so many awards and accolades, including Khandwala Best Paper Prize, Gynaecon 2020, Champion of ISAR Award. So, Dr. Amogh Chimote, the stage is yours, and we are eagerly waiting to hear to you.
Yeah. Thank you for the kind introduction, ma'am. At the outset, I would like to thank Dr. Gaurav Desai for inviting me and including me in this wonderful, unique webinar. And I wish him all the very best for his upcoming endeavors. And I also would like to give my regards to Dr. Naren Malhotra, sir. He's always been an inspiration and a motivator for all the youngsters around us. And thank you, Dr. Apoorv Kumar, for inviting me as well. So I'll be sharing my screen and be starting my talk. Yeah, just a sec. There's something which is very endometritis is becoming the hysteroscopic evaluation and the implications of chronic endometritis. So conception, as we all know, is a very complicated equation, one which I think no one has been able to solve to the T. But there has been a wonderful paper by Dr. Deepak Modi, which talks about embryo implantation and war in times of love. So what this paper tells us is that for implantation to take place, the blastocyst has to have to identify a receptive endometrium. Superimposition of that blastocyst derived signature onto the receptive endometrium before implantation, and breaching by the embryo and trophoblast invasion, culminating into the decidualization and placentation. So we all know how basically the implantation takes place. But what this paper suggests is these two important words, that is receptive endometrium. Now, this is what is alluring us. This receptive endometrium is something which is causing the problem with fertility. So let's just have a small overview about what chronic endometritis is. It is a very subtle pathology, mostly undiagnosed. Even on ultrasound, most of us are not able to visualize it. It is difficult to diagnose just clinically or by ultrasound, but it has a very important clinical relevance. And but then again, it is a reversible cause of infertility. So just to define it, it is a disorder of prolonged, continuous, mild endometrial inflammation, which is characterized by plasma cell infiltration into the endometrial stromal area. So it is actually associated with number of adverse effects in terms of reproductive outcomes, mainly the recurrent miscarriages that the patient faces, recurrent implantation failure, both in natural cycle as well as IVF cycles. And yes, obviously, primary infertility is one of the most common things associated with chronic endometritis. Now, in general population, it is present in around 1 to 9% of patients. And in infertile patient, it is between around 3 to 39 or 40% of patients. But it can be as high as 60% in women with unexplained infertility. So it forms a major chunk of unexplained infertility. So even if it is clinically silent, it decreases the success rate of both spontaneous and assisted reproductive techniques pregnancy, as well as increase the chances of complications. So this is what most of the patients do. So let's move on to the symptomatology. So basically, it is most of the times asymptomatic. Patient won't know about the presence of chronic endometritis. Pelvic pain can be present in an advanced stage. Dysfunctional uterine bleeding, yes, if it is a long enough inspection. Dyspareunia, leukorrhea, and the most important, what we'll be talking about today, is infertility. So etiology, as we know, as even Dr. Gaurav mentioned initially in the introduction of this webinar, that endometritis mostly deals with the microbial agents that cause inflammation. But a recent study by Dr. Amogh Chimote stated that chronic endometritis is an impaired inflammatory state of the endometrium, which can be caused not just by pathogens, but it can be an autoimmune reaction, it can be a genetic reaction, it can be because of hormonal imbalance. Everyone is talking about is dysbiosis. So change in the endometrial or uterine microbiota can also lead to chronic endometritis-like situation. So mind blown, right? So it's not just the bacteria and the fungi which cause endometritis. So what are the diagnostic tools that we have? We have the most basic, the lifeline, the first breath of a gynecologist, the ultrasound. Then we have our hysteroscopy. Then we have histology or histopathology, microbial culture, and immunohistochemistry. I'll be dealing mostly with the hysteroscopy part. The rest of all are maybe a topic for some other time. So let's look at the matrix of the gynecologist. So the ultrasound findings, what do we find? We generally find very thin endometrium, jagged endometrium in the pre-ovulatory early proliferative stage. There is irregular endometrial lining, and a 3D ultrasound, a coronal plane, will show you jagged edges. There will be loss of endomyometrial junction, and there will be some encroachment or increased vascularity seen at the endomyometrial junction. Then there can be chances of deformed cavity. They might not be congenital abnormalities of the uterus, but they can be strictures at the cornu, at the isthmus, in the mid cavity, causing an irregular shape of the endometrial cavity and tricking us into thinking it might be an uterine abnormality, congenital abnormality. So these are what we see over here. If you can see that, you can see a good endometrium, but when you put in the coronal view, you can see that there is some hypoechoic area over here. There is loss of endomyometrial junction differentiation over here. This indicates that there is some amount of scarring and fibrosis and on the lateral walls. Again, the same picture, when rendered properly, you can again see a fibrotic area at the level of the internal os and the isthmus. Now, these are signs of infective pathology or scarring or fibrosis that can be brought about by any kind of inflammation. It can be post-evacuation, it can be post-curettage, it can be because of chronic leukorrhea, it can be because of chronic UTI as well, that you see such pictures. Then again, this is ultrasound of another patient. Here you can see that again, the entire mid cavity region is a tubular region, which is being encroached by a slightly hyperechoic tissue. And now this particular tissue is causing a change in the shape of the endometrial cavity, and it appears as almost a T-shaped cavity. But what we can see that this is the same patient's slightly changed view. What we can see that there is a fibroid as well over here, which is compressing and causing this change in shape. So a fibroid or adenomyoma can also lead to endometritis. So now, once that we know something about the ultrasound pictures and what all needs to be done, let us see should you put in a scope or no scope as the only criteria for diagnosing endometritis. So before we go in for an hysteroscopy, we should know when to do it. So most of the endometrial leukocytes are present in the early proliferative phase, that is between day 5 to day 8, day 9, day 10. But if you do your hysteroscopies after day 12 or in the early secretory phase or the ovulatory phase, you are not going to find the pathognomic sign on hysteroscopy or even histopathology or its immunohistochemistry. So the best time to do is in the early proliferative stage. Now, moving on to a hysteroscopy video. Here we can see that these endocervical glands are also showing signs of fibrosis and scarring. As we enter the cavity, we can see that the fundus and the lateral wall both have vertical strands of fibrosis present, with dilated glands with minimal hyperemia. So these are something which are a good indicator of endometritis. In this particular patient, the CD138 count was 2%. Yeah, so now moving on to the next. Here we can see this is a most important feature of endometritis, micropolyps. Now these are something which are mostly always present in a case of endometritis. Here you can see ostial adhesion, and another striking feature of endometritis is endometrial or stromal edema. Now here we can see again that there are multiple micropolyps, there is stromal edema, there is focal hyperemia. So almost all signs of endometritis are present in this particular patient. Moving on to the next case. Here the entire endometrium has been eaten away by the infection. There is jagged endometrium, there is hyperemia, there are micropolyps, even the endocervical glands are completely lost. You can see the deep crypts of Labarcun, and there was a lot of mucus when I was entering the cavity. So these are the pathognomic features of endometritis. You have a strawberry lesion, stromal edema or endometrial edema, micropolyps, and focal or diffuse hyperemia with micropolyps. So this was one of the most groundbreaking papers I came across. This Ciccinelli et al. In May 2005 had this paper which said that endometrial micropolyps at fluid hysteroscopy suggest the existence of chronic endometritis. So they evaluated hysteroscopy versus histopathology versus immunohistochemistry, and they found that the sensitivity, specificity, positive and negative predictive value of hysteroscopy in diagnosing chronic endometritis was 54, 99, 94, and 89% respectively, with a total diagnostic accuracy of 90%. Wow. This is something that most of the tests do not give us a hysteroscopy finding, which is definitely a subjective finding, and you require some training for that. If you do not see, you cannot recognize. So first of all, you need to see. But if you know how to do a hysteroscopy, you have done enough, then you can have a 90% accuracy in diagnosing endometritis. Again, there was this paper from which examined the correlation between hysteroscopic finding and chronic endometritis. And it concluded that diagnostic accuracy of hysteroscopy is modest in untrained hands. This was a fertility sterility paper of 2019 in which two groups of clinicians or physicians were given two separate images, around 90 images each of chronic endometritis and normal endometrium. And out of this, most of them, more than 90% of the clinicians were able to diagnose and identify chronic endometritis just by looking at the videos and the images. So this just shows that hysteroscopic evaluation and diagnosis of endometritis is reproducible and can be used as one of the confirmatory diagnosis for endometritis and then start the treatment. So why does endometritis cause fertility issues? So as we had seen in the first slide, that there are multiple mediators like leukocytes, cytokines, chemokines, and other endometrial factors, which are responsible for bringing about the interaction between the blastocyst and the endometrium and having a receptive endometrium, and hence bring about conception. Presence of endometritis or chronic endometritis, it alters the receptivity of this endometrium by disrupting and increasing maybe the natural killer, uterine natural killer cells. You have TNF alphas, you have other inflammatory, pro-inflammatory chemokines present in the milieu, which causes a non-receptive endometrium and brings about problems with implantation. So another theory is there is high level of estrogen receptor, progesterone, and Ki-67 nuclear marker for cell proliferation in both epithelial as well as stromal cell. This increased expression of the anti-apoptosis genes such as BCL2 and BAX brings or keeps the endometrium in the proliferative state, even if by dates the patient is in secretory state. So it brings about a delayed conversion of endometrium from a proliferative to a secretory stage, and this disrupts the normal cycle of implantation. So when we expect implantation maybe on day 20, day 21, or in an IVF cycle when we do a embryo transfer, when we time it, all these dysregulated factor will be one of the causes for implantation failure. So there is alteration of pattern of the uterine contractility. As we know, in proliferative phase, there is an antegrade contractility from the fundus to the cervix to remove the remaining debris and some fluid, if at all present inside the cavity, and move it aside. In the periovulatory and the luteal phase, this movement goes from the cervix to the fundus to facilitate the swimming of the sperm towards the egg. But there has been reports that say that chronic endometritis leads to 3.3 times lower occurrence of retrograde contractility. That is, that shift from fundus to cervix to fundus does not take place in most of the cases in patients with chronic endometritis. So this again is one of the factors by which chronic endometritis disrupts conception. So what is the impact on IVF cycle? So it is mostly controversial, but again, endometrial receptivity, presence of IgM, IgG, and IgE alteration in genes encoding proteins involved in inflammatory response, proliferation, and apoptosis. So these were the two papers which were actually helping in how to diagnose and help in management of chronic endometritis. So the first paper was from 2010 by McKenna et al., which has stated that chronic endometritis is a frequent finding in women with recurrent implantation failure after IVF. So implantation failure, it actually warrants investigation for chronic endometritis as a contributing factor, and women demonstrating endometritis on endometrial sampling have lower implantation rate in subsequent IVF ET, but there was no difference in subsequent clinical pregnancy or ongoing pregnancy rate after successful antibiotic treatment. So here comes in the role of other factors responsible for endometritis, namely endometriosis, maybe fibroids, maybe autoimmune factors. So all these and dysbiosis, all these factors can also cause problems with implantation. Again, it was Ciccilinelli et al. In 2015, which stated that prevalence of chronic endometritis in repeated unexplained implantation failure and the IVF success rate after antibiotic therapy. So here again, recurrent implantation failure was a hysteroscopic evaluation was done. Chronic endometritis was excluded, appropriate antibiotic treatment was given, and then the IVF should be attempted. So again, a paper in support of hysteroscopy, the value of hysteroscopy in diagnosis of chronic endometritis in patients with unexplained recurrent spontaneous abortion. So the objective was to investigate the role of chronic endometritis in unexplained recurrent abortions and to determine the correlation between hysteroscopic and histological finding of chronic endometritis. So it concluded that chronic endometritis is associated with unexplained abortions, and hysteroscopy has high sensitivity, acceptability, specificity, and is suitable for diagnosis of chronic endometritis in patients with recurrent spontaneous abortions. So, along with ultrasound, hysteroscopy is definitely the tool for diagnosing endometritis. And on histopathology, the presence of plasma cells in endometrial stoma has been accepted as the criterion for standard method to establish chronic endometritis. So quickly moving to the treatment. So now this is something which is again a big topic, and I'll try to just take it into headings. So antibiotics, mostly what we give is a treatment for PID. So most common antibiotics that we use are doxy, metro. Levoflox is something which can be tolerated much better by both by the patients. And another is ciprofloxacin can also be given if it is a chronic and not managed or cannot be treated completely by the empirical basic antibiotics. Second role of antibiotics come when you do a microbial culture. So one thing that I do personally is when you do a hysteroscopy, most of the surface epithelium and the surface fluid is washed away. And when you do a culture of the endometrial biopsy, you take an endometrial biopsy, you send it for culture, it comes out to be negative. In cases where there was chronic endometritis and I had to do a large lateral metroplasty or a large septum along with endometritis, and I put in a Foley's catheter, I sent the tip for culture, and every time, almost 91 to 92% of the times, I got a positive culture. That indicates that with chronic endometritis, the culture has to be done after the patient goes into a secretory phase. So after you get a culture, start the antibiotics which are sensitive to the bacteria or the organism isolated. And these antibiotic cycles should be given for at least 2 to 3 cycles. That is 14 to 21 days of cycle have to be given at least for 2 to 3 months. Reevaluate the patient. On ultrasound, you will see changes in the markers of endometritis. Anti-inflammatory, yes, in patients who have CD56 positive, in those patients, I started with anti-inflammatory as well as some amount of immunomodulatory drugs like hydroxychloroquine. So this has given us a very good resolution of the chronic endometritis, which did not have a culture positive or CD138 positive or any plasma cells in the histopathology or any signs on hysteroscopy. So such patients whose CD56 is positive, they respond much better to anti-inflammatory as well as immunomodulatory drugs. In such patients, if you're going in for an IVF with CD56 positive, it is always better to start the patient on prednisolone at a low dose, maybe 4 milligram or 8 milligram OD or BD depending on the body mass index. If the patient has endometriosis or adenomyosis, yes, laparoscopy might be warranted in endometriomas more than 5 centimeters, or if the pelvis appears to be frozen, it has to be dealt with. Start the patient maybe on Lupride, maybe Dynogest, or what I personally use nowadays is dydrogesterone. A high dose of dydrogesterone for 3 to 6 months reduces the amount of endometriosis as well as adenomyosis significantly. Immunomodulators, as I mentioned, yes, you can use hydroxychloroquine 400 or you can use prednisolone 4 to 8 milligrams. So this is in short about the treatment. So to conclude, it is a chronic endometritis is a multi-etiological entity, and it is not just microbial. Hysteroscopy as a diagnostic tool for evaluation is quite reliable in experienced and well-trained hands. Histopathology and immunohistochemistry, mainly CD56, CD138, are good tools for confirming the diagnosis if you are in doubt. Culture may be required if there is resistant to antibiotic treatment and specific antibiotics need to be started. A combination of antibiotic and specific drugs depending on the pathology like the fibroids, endometriosis, adenomyosis, or dysbiosis. So even your lactobacilli, probiotics may help in improving the chronic endometritis condition. So when I started preparing for this lecture, I just typed in chronic endometritis, right, on Google. And what I see, the most of the images that I got were of hysteroscopy. So hence, I would like to conclude by saying hysteroscopy as a confirmative diagnostic tool for a chronic endometritis, and then the management is definitely here to stay. So with this, I conclude my talk, and I thank you all for a very patient hearing.
Thank you, Amogh.
Thank you, Dr. Amogh, for this wonderful talk. May I invite the chairpersons to kindly give their valuable comments?
Yeah, Dr. Amogh, that was a brilliant presentation. You discussed all the nuances of endometritis, and truly it is a very important cause of recurrent implantation failure, the recurrent unexplained abortions. And indeed, of course, ultrasound helps in diagnosis, but it is truly the hysteroscopy which can lead to a better diagnosis. And you also discussed about the various treatment options, especially the use of antibiotics and the immunomodulators. And you also told that you use dydrogesterone in high doses.
Yeah.
So that was brilliant.
Thank you, ma'am.
Dr. Amogh, I think personally I met once or twice with you in a conference, but I have been following you and we are connected in a lot of platforms, social platform, and you are such a decorated doctor. And a wonderful person,
Nothing
a
in front
great
of you, Dr.
friend,
Apur.
and a party person, and above all, a wonderful laparoscopic surgeon, infertility specialist. So
Thank
it's
you, sir.
really an awesome to chair your session. When Gaurav told me that you have to chair a session where Dr. Amogh is giving a talk on hysteroscopy, I was so excited.
Oh,
So
thank you so much,
really,
sir.
it was really and brilliant and talk. Like hysteroscopy, I just want to tell everyone because, you know, in our place, like where I am working in a very small place, where the laparoscopy and hysteroscopy, endoscopy are not so common. So I just wanted to give them a basic thing. Whenever you are evaluating a patient of infertility, you should take hysteroscopy as at least if not even a first line, but you should always take, because previously, you know, for the secretary page we are doing in simple DNC, but this is DNC should not be to it's actually associated and it should be club with the hysteroscopy. Then definitely the diagnostic value is really very high. So thank you so much for really a wonderful talk, and really looking forward to meet you in near future. So thank you. And thank you so much, Gaurav, for a great webinar, and all the very best for your future endeavor. Thank you so much, Gaurav.
Thank you.
Thank you. And thank you, Amogh.
Aarti, we'll move on.
For this, Dr. Amogh, I would like to add something. In the recent hysteroscopy world discussion group, which was there, so now everybody is after that they should remove this terminology of chronic endometritis and replace this terminology with the inflammatory
stromal endometrial
endometrium, which is ILSE. So all over the world, there are a lot of talk going on this, because in the world scenario, globally, they don't recognize this term as chronic endometritis, because we in India and the Asian people, we face this inflammatory states more. Maybe it is because of the subclinical exposure to tuberculosis or other entities. We have more of infective pathologies with the endometrium, whereas in the rest of the world, they don't admit to these. So they are trying to modify this term and include in a broader sense by naming it as impaired inflammatory state of endometrium.
Right.
Aarti, I just wanted to add, because the chronic endometritis, even and other things now, even in small places, villages, patients and the young ladies are not using, you know, the sanitary pads. They are still using the clothes, and the clothes which are actually the old clothes, and it is definitely a source of infection. So what I feel that in our places or in the third world, where the developing country, this endometritis is really very common, other than the Western countries. That is the important thing.
Yeah, I totally agree with that. Thank you, Dr. Apurva Datta. So moving ahead with the webinar, can we go ahead with the next speaker? I'll be sharing my screen. Next, I would like to welcome Dr. Surakshit Battina to present his talk on laparoscopic management of cervical agenesis. For this, we have Dr. Supriya Jaiswal ma'am as the chairperson. She is the consultant at SM Hospital Patna and is the chairperson of Adolescent Health Committee of FOGSI. And I welcome you, ma'am, and for kindly allowing us to hold this webinar along with SAFOG and ISAR. She is also the vice president of Patna Obs and Gynae Society and is a co-trainer of HPV project in the East Zone. She's also been the joint secretary of multiple societies and is an executive member of ISOPAR, ISAR, and IAG of Bihar. I welcome you, ma'am, and she has multiple publications to her name and has recently given the FOGSI GCPR on menstrual hygiene. Welcome, ma'am.
Thank you.
I also welcome Dr. Isha Kriplani, a dear friend and a senior to me. She's a consultant at Paras Hospital, Gurugram, and I have learned a lot from Dr. Isha, ma'am. She has been a faculty in gynae-based surgical program at Paras Hospital. She is a program coordinator in laparoscopy training courses. Along with Dr. Alka Kriplani, ma'am, she's hosted multiple training programs and is really a wonderful teacher. I have learned multiple small tips and tricks from Dr. Isha. Welcome, ma'am.
Thank you, Aarti.
I also take the pleasure to invite Dr. Ramani Devi, ma'am. It will be very injustice if I keep on reading ma'am's CV. She has she's a lady who reads no introduction. She's the managing director of Ramakrishna Medical Center and Janani Fertility Center and has received multiple medals and awards to her name. She has been the winner of multiple awards like the CS Dawn Prize of 2006, 7 and 2013, and has also received the Indumati Zaveri Prize. She's been the chairperson of endometriosis committee of FOGSI from 2014 to 16, and she has also received Women of the Year award in 2000.
I think that is enough, ma'am. Enough.
Yes, ma'am. I cannot go on listing your multiple achievements that you have received. Thank you.
Hello, madam. Good to see you.
Hello, ma'am.
Yeah. Thank you for the kind introduction.
I would request one of the chairpersons to kindly introduce our speaker for today, Dr. Surakshit Battina.
Shall I introduce?
Yes.
Surakshit is from our place. Surakshit Battina is a FICRS Scholar USA, Fellowship in MIS France. He has also a fellow in reproductive medicine from UK, fellow in cosmetic gynecology from UK, founder in Indigo Women's Center and TEDx speaker, and performed the world's first laparoscopic management of uterine rupture, and IAG Young Excellence Star Award winner and winner of the Icon Award for 2019. Let us listen from Surakshit Battina. I wouldn't say it is not uncommon because we do come across many cases of cervical agenesis, and earlier, when a decade ago, nothing could be done only other than hysterectomy. But now we know that we can reconstruct the cervicovaginal passage and make these young girls free of the dysmenorrhea and other severe chronic abdominal pain. And also they have a chance of going in for a good reproductive career. So with this introduction, I would like to hear from Dr. Surakshit Battina regarding his technique of laparoscopic cervical agenesis repair.
Thank you so much, Ramani ma'am, for that wonderful introduction. I would like to thank Gaurav and Aarti for making me come here today and present this talk. Let me share my screen. The host is disabled. Can I have the screen sharing, please?
Yeah, Aarti, can you let him?
I have made you co-host, Dr. Surakshit. You can share your screen now.
Okay, yeah, perfect. Thank you. All right. Perfect. Okay, so if you are looking at cervical agenesis, right, what are the things we need to understand? Number one, it's a very rare congenital anomaly. 1 in every 100,000 live births, symptoms are basically primary amenorrhea, primary infertility, cyclical abdominal pain. The problem is, I've been trying to make this slide even more technical, have more data in that, but unfortunately, there's just so little data available online on this. Okay, so when you're looking at the X-ray classification, this is a newer one. So where this one comes in is this particular cervical aplasia, which is C4. And also we have another Rock et al. Classification, which I have seen, which comes under type 1, which is cervical aplasia, which is a lack of uterine cervix, right? When you're looking at the treatment options, we have three various options, which, as madam was saying, previously they used to go in for hysterectomy. Nowadays, we are trying the whole coring and drilling technique. Somehow, I have seen in many places they are doing this whole coring and drilling technique, but the case I'm going to show you, I have done the uterovaginal anastomosis, and it worked quite well for the patient. Overall success rate, you see, it is around 60%, right? The complications are endometriosis, PID, persistent pelvic pain, bowel and bladder injury during the surgery, reobstruction, stenosis, because this is very common. Stenosis is very, very common in these women. So that is something that we need to look out for. And also the creation of a neovagina and uterine opening. Okay, it has to be done as early as possible, maybe at around 12 to 14 years, because this will avoid the chance of endometriosis. In fact, if you see the patient who I have operated, she was around 22, 23. She had severe pain every cycle, and also she had grade 2 or grade 3 endometriosis. Now here you can see like how, just a pictographic representation of how you actually correct this issue. And for the further pregnancies, I've also seen there was some data, although the patient who I operated on hasn't conceived yet. Pregnancy is possible in such cases, and there have been 9 reported cases of pregnancies after conservative management. However, what I understood is that no one has actually addressed about the cervical incompetence bit, because I feel these people, since they don't have the cervix, right, they have a higher probability of cervical incompetence, but somehow in all the data, they have really not mentioned about the cervical incompetence. So I'm really curious to know if any of the audience have any, data on that. This is the surgery. I'm going to show it to you right now.
Hi, in this video,
are you able to hear the audio?
To you the laparoscopic management of a patient with cervical agenesis. We are going to demonstrate the performing of uterovaginal anastomosis. Adhesions within the pelvis are now being completely cleared.
So as you can see, this lady also had, I told you, they have a lot of renal anomalies. This one had a pelvic kidney. You can see it's well down and it's in the pelvis. So slowly and steadily, we're removing all the adhesions. And you can see she already has grade 2, grade 3 endometriosis.
Once the uterus is identified, a stitch is placed on the fundus of the uterus for manipulation.
Since these people, you cannot put in a dilator, or you can't put anything through the vagina because there's a agenesis of the cervix, you have to use the, stitch on the uterus to give you manipulation.
The UV fold of peritoneum is now cut and the bladder is pushed down.
You can notice how the cervical part is really thin and very small because of the whole agenesis. See, it's more like a fibrous band. That's all, nothing more than that. Can you see that?
A probe is placed within the vagina to identify its borders.
So we just had to put a
probe.
Vasopressin
is now injected into the fundus of the uterus. Using the harmonic scalpel, the uterus is completely bisected within the center up till we reach the endometrium.
So this step is very important. You have to bisect the uterus. Otherwise, you will not be able to, fix this issue. So as you can see, once you come to the lower side, there's absolutely nothing there. You can always see the hematometra, not the hematometra, I'm sorry. You have the fluid which has been collected inside the endometrial cavity, because there's nowhere else for the fluid to go out. So either it comes into the pelvis and becomes endometriosis.
After the uterus is completely bisected, an opening is made in the vaginal canal.
So we still have a probe inside the vaginal canal. So using that probe, no, we are just making small incision with the harmonic scalpel over the agenesis part. I mean, on the vagina.
A part of the redundant tissue.
We do have a small agenesis part of the cervix, which usually is present for all the cases. We've done around 3 cases like this, and all of them have that small redundant part over there. So now you can see the vagina has been
The
completely opened.
right-sided hydrosalpinx is now removed.
So this patient had a huge hydrosalpinx, so we didn't want to keep it in the pelvis. So we're just removing it because right now the vagina is open. So we want to use that opportunity to go ahead and, you know, release it and remove it through the vagina.
And the left-sided ovarian chocolate cyst is now being drained.
Now we're doing the cystectomy, just removing the whole diseased endometrial, the part of the endometrioma along with the tube. A little more redundant tissue was there in the posterior aspect of the vagina, which we are still removing right now.
Using non-absorbable 2-0 sutures, we first take a stitch through the posterior surface of the vagina and hitch it to the posterior surface of the uterus.
This is a very important step. You need to understand that the stitch has to come in the posterior aspect of the uterus. Over here, you can see the stitch is coming in the posterior aspect. You should not have the stitch which is coming inside the vagina because again, it can cause some kind of granulation tissue. So you don't want that. That's why the stitch has to come outside.
A silicone catheter is now placed into the uterine cavity.
Your first stitch should always be the 6 o'clock stitch. Don't put the initial one, the 12 o'clock stitch initially, because this way you'll be able to approximate the vagina to the cervix. Sorry, vagina to the uterus. Always put the lateral sutures first. This is again using the non-absorbable suture.
And using additional 2-0 non-absorbable sutures, we are able to bring the vagina closer to the uterus.
So already you can see the anastomosis, coming beautifully. So just put as many additional sutures as you require just to bring the uterus to the vagina.
Once the vagina is completely approximated with the uterus, we now start closing the uterine defect with continuous barb suturing.
I have just placed 1 or 2 more stitches over here because, just to give a little bit of, support to the tissues using the non-absorbable suture. Now we have started using the V-lock absorbable suture, V-lock barb suture to close the defect completely. Sometimes you can use 2 layers. In this case, I used only 1 layer. Just the second layer was just a very superficial one. And any additional sutures in the vagina, if required, you can take it at the end. So now you can see the vagina has been...
A thorough suctioning and irrigation is done in the pelvic cavity.
Vagina is hitched to the cervix. Sorry, to the uterus.
An interseed is placed over the uterus to prevent further adhesions.
if in case we had to, do this procedure again for the patient, or, because of stenosis.
Thank you all so much for watching.
Because of stenosis, right? Sometimes most of these patients might require research. So that's the reason why we had to go ahead and, place this thing. Again, post-operatively for this, it's, so far only a Foley's catheter you can keep. Some people have put it for 1 week. I've decided to put 4 weeks for this patient, and good, for now, even the patient is having regular menstruation, and, the patency is maintained quite well. So I think 4 weeks should be quite okay. Again, what we need to understand, one thing which, especially for all of these women, is that we don't really consider the mental health. That is something that we need to really give in a lot of thought in, because you need to talk about the initial, we just tell them, what, you have to go for procedure, this is what, but whatever trauma they've gone through and whatever trauma they will have to go through, additionally, if in case they require any more surgeries and, about their pregnancy and everything else, you'll have to really talk about it. What I've done is like put into 4 stages. I spoke to my psychologist as well, and they usually do the initial emotional impact, the long-term psychological effects, the coping strategies, and also they put them up with other communities as well, so that other people are having the same concerns, so they both can share their stories and then know more about it. So that's it for my talk. Thank you so much for hearing.
Thank you, Dr. Surakshit. May I now request the chairpersons to kindly give the valuable comments, please?
Yeah, thank you, Dr. Aarti. Actually, on the answer, I'll start with the greetings from my committee, that is the Adolescent Health Committee, FOGSI, and it was wonderful to have this webinar, SAFOG-FOGSI-ISAR, along with the Adolescent and Sexual Health Committee, FOGSI. And special regards to our chief guest, Dr. Bhaskar Pal, Dr. Asha Bakshi, and the guest of honor, who's teacher of teachers, Dr. Naren Malhotra, sir. And special reference to Dr. Jaideep Tank and Madhavi, madam. Thank you, Dr. Gaurav, for having me on this panel. And Dr. Apurva, a very active adolescent, active young budding star of FOGSI. And Dr. Aarti, you're lovely. Your coordination is wonderful. So coming to the topic, Dr. Surakshit, you have said, presented the topic that was much less talked about, very less talked about, but you have presented it so well, so nicely. Whatever you could do, I know you won't get much data about this, but you have presented your talk in a wonderful way so that we could all understand and take. And in adolescence, I really want to talk more about the adolescents, because there are many things that they hide, and it is difficult to go for surgery in those cases. And in this particular case, what you said, that outcomes really, the overall success rate of conservative surgery, what you said was 60%, is really true. And we had lots of complications that you said, endometritis, pelvic inflammatory disease, reobstruction, and stenosis. So requiring reoperation is really, really very painful and not acceptable at all. And the new vagina creation, everything you have explained so well. So I really congratulate you for a wonderful, wonderful presentation on a very less exposed topic. Thank you so much.
Thank you, Dr. Supriya. Thank you.
Yeah, Ramani Devi, madam.
Yes, I think he has brought out the points, laparoscopic management, excellently. One point I would like to stress is, in adolescent girls, whether they have primary amenorrhea or whether they menstruate, if there is a cyclical pain, which later on becomes a chronic pelvic pain, always think something about the Mullerian anomaly, because Mullerian anomalies are not so uncommon. We do come across a lot of these patients. And the main thing is, if you can pick it up at a very early stage, even before the organ damage like the loss of tubes or the endometriosis that can happen, that can be corrected. And I really appreciate Surakshit for expressing about the psychological things these young girls, they get. So that can also be avoided if all these things can be corrected at a very early stage. So it was a wonderful work, Dr. Surakshit, and I wish you all the best for your future endeavors. Thank you for the opportunity given Dr. Gaurav, and wish you success in your future venture. Thank you.
Thank you, madam.
Same here, Dr. Gaurav and Dr. Surakshit. All the best for your future endeavors from myself. And thank you, Ramani Devi, madam. Thank you. Honor to be chairing the session with you.
Thank you.
Just wanted to say that Surakshit loves endoscopy so much. During COVID, when all the chaos was going on in the world, Surakshit and I were discussing endoscopy. So anyway, Dr. Isha, anything you would like to say?
Yes, congratulations, Dr. Surakshit, on the wonderful talk on such a unusual and rare topic, and for the demonstration of an excellent laparoscopic surgical video of such a rare pathology. There are a few things I would like to add, as Dr. Surakshit very importantly highlighted the importance of mental health in such cases. You know, in our country, where in our society, menses are actually celebrated. It is very important to understand that when girls with cervical agenesis and other Mullerian anomalies come with cyclical abdominal pain and they are advised hysterectomy, it is a big psychological thing for them to overcome. It is understandable that the success rate is lower with these situations. But earlier, as hysterectomy used to be advised much more frequently than now, and to think in an era where uterine transplant is successful, we were removing uterus where, you know, there was just one part that was agenetic. So endoscopy and our understanding of the Mullerian anomalies has really revolutionized treatment for these patients. Things I would like to add, according to the experience I have gained in seeing such cases. One is that when we see hydrosalpinx in such cases or hematosalpinx, it is wise to drain the hydrosalpinx or hematosalpinx and let it heal. It is not important or necessary to do salpingectomy in all of these cases, because many times, because of the endometriosis and retrograde menstruation, there may be inflammation which will settle down with time, and these tubes might even give successful pregnancies. So we don't always need to do a salpingectomy. And the second thing is, many a times in cases of cervical agenesis, we need to leave the intrauterine catheter for longer, sometimes even up to 6 months, and then after removing, at a 6-month interval, these patients even require repeat insertion of an intrauterine catheter because of stenosis. So also one good idea when you are leaving the intrauterine catheter is you can tie the tip of the catheter to the fundus with an absorbable suture. So it will at least stay for, 4 or 6 weeks and it won't get expelled spontaneously. That's all I'd like to add. It was really a wonderful lecture and an excellent video presentation, Dr. Surakshit.
Thank you. Thank you so much.
Thank you. We'll move on.
Yeah, moving ahead with our further presentation, I can see Dr. Smeet Patel is already here. I welcome Dr. Smeet Patel, sir, to present talk on...
Rightly.
Yes, Dr. Ramani Devi ma'am wants to say something. Okay, moving ahead, we have the next talk on fantastic tissues and where to find them, a surgeon's perspective on endometriosis tissues across the pelvis. So I would welcome Dr. Smeet Patel. Before that, I would also want to welcome the chairpersons for this session, Dr. Arna Suman, madam. Dr. Smeet, can you just exit your screen sharing for a minute?
That's okay, Dr. Aarti.
Welcome, ma'am, for this webinar. Thank you for joining in. I know you're in US right now, and thank you for joining. Ma'am is professor of and head HOD of the Government Medical College in Telangana. She's been the Joint Secretary of FOGSI in 2021 and has been the organizing secretary for the wonderfully organized AICOG Hyderabad 2024. Ma'am is also the national coordinator for No to Violence Against Women Committee. Next, we have Dr. Kiranmai Devineni, madam. I welcome you, ma'am. Ma'am is a chairperson FOGSI No to Violence Against a Women Committee 2022 to 2025 and is a core member of FOGSI. She has been the receiver of multiple awards and has multiple publications to her name. Ma'am has organized multiple conferences in national and international levels, and she has been the Kamini Rao Yuva FOGSI orator in 2013. I welcome you, ma'am. I would like to request one of the chairpersons to kindly introduce Dr. Smeet Patel, sir.
Yes, Dr. Aarti.
Ritika. She's also there. Ritika, madam. Are you?
Dr. Ritika, ma'am.
Yes, sir.
I would like to welcome Dr. Ritika ma'am to also chair this session. We missed the previous sessions, ma'am. Kindly chair. I request you to chair this current session.
Thank you. I was just in OT. I just came back.
Kindly introduce our next speaker, one.
Yes.
I would request you, ma'am.
My sincere thanks to Dr. Gaurav Desai, Dr. Apurva Datta, and Dr. Supriya Jaiswal, and Dr. Aarti Chitkara for this great opportunity. I would like to introduce, can I have his CV, please? Yeah. Dr. Smeet Patel. He's a director of Mayflower Women's Hospital, Center of Excellence in Endometriosis and Gynec Oncology. His career profile, actually about him, he's been the president of Junior Doctors Association Gujarat 2017-19, managing committee member of Ahmedabad Medical Association Gujarat 2019 and 21, key interest in gynec oncosurgeries and endometriosis surgeries, expertise in high-risk obstetrics and gynec laparoscopic surgeries. He's got many publications and video publications too. I welcome Dr. Smeet Patel. Please take over and present.
Thank you very much, ma'am, for the introduction. At the onset, I would like to thank and greet everybody, all the dignitaries here. I would like to start my presentation. So today I'm going to speak on endometriosis. And so endometriosis is a deep forest, and we have different kind of tissue types in the forest. And today we are going to discuss from a surgeon's perspective how these tissues are. And we're going to find 8 different types of tissues. So let's look into some mysterious, dangerous, but very interesting pathologies of endometriosis, the tissue type. In the next few minutes, we are going to uncover and understand these mysteries. So I have titled this topic as Fantastic Tissue and Where to Find Them. We have segregated that into 8 different categories of tissue, and each tissue is different from the last, but yet they all look the same way. So let's dive in. The first one is Red Riding Hood. These are heavily angiogenetic, bleeds upon touch, and occurs on superficially. So as a surgeon, we always come across endometriosis surgery, and those surgeries are quite messy. They are always messy, bloody in nature. If you are able to take care of this angiogenetic part, the supply of the vascular to that endometriotic tissue, your field can be very neat and clean. Moving on, the next type of tissue is Charis and Chalice. These are fluid-filled cysts, often concealed and of varying consent. So like you can see here, a proper traction and a counter traction is needed if we are able to do a complete removal of those fluid-filled cysts of endometriosis. Nothing better like that, and it is always going to have a great margin of surgery as well. The next, we have plucky peaches. These are cystic fibrotic tissue, unclear margins, and angles and organ. So in case of an adenomyosis, there is always it is not like a fibroid. It is something like unclear margin, dense, fibrous tissue, sometimes encompassing a cystic mass in it. In this kind of cases, it is of paramount importance that we remove the surrounding fibrotic part and the volcanic cyst in the center. Next, we have a bundle of woos, the fibrotic tissue. These are thick and dense. We mostly call them the fibrotic tissue, the white plaques. And these are very important because this actually defines our planes of surgery. So giving proper traction and counter traction, we can enter into the right plane and dissect those plaques away. Next, we have poison pills. This is on the rise, and these are dense, rubbery in consistency. So most of the times, there is always a medical management which precedes a surgical stance. So all this medical management will tend to decrease the elastic nature of the endometriotic plaque. So for example, an endometriosis, the tissue always grows in a layer by layer fashion. So there's a nodule under the influence of hormone, it is going to grow, it is going to shed, and there's a fibrotic. In the next cycle, again, the same cycle is going to be there. So it is always going to go in a layer by layer, and the endometrial tissue is going to have a parenchymatous nature. But under the influence of hormones, this parenchymatous nature is not there. It is going to shrink and constrict. There's going to be a rubbery density and consistency. We cannot give proper traction and counter traction, and it does not cut easily also. So whenever post-medical management, we always find a difficulty in doing surgery, and this is because of the inelasticity which is developed because of the management itself. Next, we have the resurrected. These are active glandular tissue, and they are flimsy to touch. So this mostly mimics the endometrial glands in the uterus, and most of the times it is found on the posterior aspect of the uterus at the torus utrinus plaque, at the rectovaginal plaque. And it is very flimsy to touch. It is something like the gland itself, and they are very active. So removing this tissue is very important because they are going to grow in a very invasive way. We have flary felines, or I like calling them flary felines also. These are post-surgical tissue growth. These are intense plaque formation. So any surgery for endometriosis, and the leftover tissue is going to grow in an unorganized way. They are going to grow not in a controlled sense. So post-surgery of endometriosis, it is going to grow in a way which is not proper, or it is not confirmed, or it is not what we say, uska iman dharam nahi hai. And we will always find dense endometriotic tissues post that. And taking and doing a surgery on those kind of patients is very challenging as well. Next, we have swarm of sorrows. These are infective endometriotic tissues, and it proliferates in closed compartments. So most of the times it is because of the PID, or in case of multiple ovum pickups, what actually happens is the needle for ovum pickup is passed from the vagina into the rectum in case of rectovaginal plaque, and into the ovary. So you are actually like giving the whole infective part to the ovary, and the whole endometrioma is churned down with the infective foci, and this is what it forms. Sadly, in such kind of cases, we have to remove the ovary most of the time, but if it is salvageable, we always try for that. So these tissues are like they are very good friend of theirs, and they always occur in a good friendship. They'll be in multiple permutation combinations. Sometimes they'll stand alone, or most of the times they'll be in different permutation of combination. Like we'll have angiogenetic, we'll have fibrotic, we'll have Charlie's and Cherries in ovaries, we'll have the woos in dense fibrotic area. So there might be multiple permutation combination just with 8 different tissue types. We have somewhere around 256 different tissue taxonomy altogether. This was published first on our newsletters on Endometriosis Weekly, and any questions, I'll be happy to answer them.
That's a really novel and interesting way of identifying and differentiating the tissues and in giving them certain characteristics and all. Wonderful presentation, Dr. Smeet.
Thank you very much.
So just wanted to ask, you have elaborated in detail about the tissues, but definitely the precautions and the complications and the instrumentation also would differ with the type of tissues. Any specific inputs on the type of instrumentation and everything, that the energy sources that you choose depending on the various tissues that you have described?
So there is not a big difference. So surgical steps always is the same. We always follow the certain mathematics for endometriosis, and for the energy source, we are fond of ultrasonic scalpel. So we always, I find Harmonic, the new latest version 1100, to be a very fantastic tool, and it's a great dissector. So always helps us with great dissection and removing those nodules.
So the division of the tissues into these various types that you have told, the primary basic intention or the usefulness that I wanted to learn further.
Endometriosis is a vast topic. I don't think we have time.
No, the 8 types of tissues that you have told. It is out
Yes.
of interest. I'm asking that. Have you studied the basic purpose of dividing or defining them into the
So,
8
ma'am,
whatever?
the basic purpose being from a surgeon's perspective, whenever we go inside the pelvis, it is a Pandora's box, right? So we do have some kind of idea that these are the type of tissues, and how we approach these tissues is very important. I was very brief about, like, if you are having an angiogenetic tissues, stay a bit away from the main plaque. You will be able to take care of all the angiogenetic vessels and then remove the plaque. If it's there is in adenomyosis, if it's a fibrotic part, unclear margins, but it has a central cystic collection, it acts as a volcano. So always remove such kind of tissues. In case of like previously operated for, previous medical management was given on those patients for a very long time, then the tissue is going to be like without any elasticity. The surgery becomes very complicated. The planes of dissection are altered in those cases. So yes, there's always a surgical approach there to different tissue types.
The anticipation itself and the expectation itself will help a lot surgeon in approaching it. So fantastic and out of the box presentation, I would say. Appreciate really a wonderful presentation, and I thank Dr. Gaurav for this invitation to be part of this webinar, and also congratulate Dr. Apurva, Dr. Supriya, and Dr. Aarti for conducting this so well.
Thank you, madam.
Thank you.
Aruna Suman, ma'am, any comments?
Yeah.
That's a beautiful storytelling. You made things so easy, Dr. Smeet Patel. It is really like you showed us a real movie, but I don't think it is so easy to operate, right? So definitely
really very
it's
easy,
excellent.
right?
Yeah, but you made it very beautifully. You have presented.
I mean, it is really interesting to understand the various types of tissues.
Novel, yes, we were able to understand it properly, and you'll have to, yes, and you'll have to read it and do it further to practically experience the different kind of tissues that you have presented. Thank you so much. That was a really excellent presentation.
Thank you
Dr.
very much.
Ritika Agarwal is there.
Yes, ma'am. Thank you, ma'am, for giving me this opportunity to be amongst the stalwart like Bhaskar Pal sir, Asha Bakshi ma'am, and Naren Malhotra sir. Thanks especially to Dr. Gaurav Desai for giving me this opportunity, and Dr. Aarti for conducting it very well. Dr. Sumit, it was a beautiful presentation. You had correlated the presentation with day-to-day things. It is so easy for the people who are not dealing with laparoscopy daily. We could actually picturize and correlate what the things must be like inside. So great presentation.
Thank you.
Dr. Ritika madam is joined all the way from Moradabad. So I must acknowledge her. She was caught up in a cesarean section, but
I am really sorry for that.
Yeah, no problem. But I think Smeet, you have I think all the chairpersons have given you an idea to make a movie. So if you make it, just let us know.
I think he's
We'll
already
buy
in
the
the
ticket.
process of making some movie.
Yeah. I'll be the first to ask for a ticket.
Even we will watch it, Dr. Gaurav.
Yeah.
We are there.
There is one movie is already there by some Mexican endometriosis people, Dr. Ram, I think Ram Cabrera. He was also present in one of the endometriosis. This thing was there in Hyderabad. So it is named as Below the Belt. There is a movie already on it. So I think hopefully next week
actually, the title of the presentation was really piqued the interest.
So we should congratulate Gaurav, I think, for the topic that he has selected.
It was very interesting.
Aarti, move on. The next talk
Thank
is
you.
equally good, if not better.
Moving ahead with the next talk, I would like to invite Dr. Subhash Naval. Can I just share my screen? We have another interesting talk by Dr. Subhash Naval sir, who's more famous for his V notes. But today he's giving us a different topic, which is microwave ablation of adenomyosis. For that, I would like to invite our respected chairpersons, Dr. Nisha Kapoor, madam. She is the current chairperson for Haryana chapter of IAGE, has been the past president of Faridabad Obs and Gynae Society, and is also the vice president of Haryana Association of Obs and Gynae. Ma'am has multiple chapters to her name and has a special interest in endoscopy. She's also a famous endoscopy trainer in Faridabad. I welcome you, madam. Also, I would like to invite Dr. Meenakshi Goyal, madam. She has been practicing endoscopy in Hisar and is a renowned name. She is working at the ND hospital in Hisar and is a joint secretary of Haryana chapter of IAG. She's also a member of the FOGSI Endoscopic Committee. I welcome you, madam. I would like to request one of the chairpersons to kindly introduce Dr. Subhash Naval, sir.
Good evening, everyone. Thank you, Dr. Addi, for giving me the opportunity to be a part of this wonderful event. Well, it's a pleasure to introduce Dr. Subhash Naval. He is very well known for V notes, but today we are hearing from him on a different topic. So he's a gynecological endoscopic surgeon, vaginal surgeon, and V notes expert at Naval Multi-Speciality Hospital, Jalgaon, and KLSM Hospital, Mumbai, and Shruta Hospital, Wardha, and Kingsway Hospital, Nagpur. He is appointed as V notes expert member by International Notes Society, and he is founder V notes Academy of India. And his innovations, we all know, novel note sync device, then atrium technique of V notes, hystectomy, pure V notes, power modulation in bag, and guestless V notes. So, Dr. Naval, we are eager to hear from you on a topic which is quite popular nowadays, and we are looking forward to the minimally invasive management of adenomyosis by microwave diathermy. Thank you. We are welcome, Dr. Naval.
Thank you so much, Madam, for kind introduction. And I must thank Gaurav and Aarti for making me a part of this wonderful webinar. And let me share my screen. And my best regards to all the seniors and respected teachers present here. And with the permission of chairpersons, I would like to start my presentation.
Sure.
Yeah. So my topic is microwave ablation of adenomyosis. And I will be particularly focusing on the technique of doing the microwave ablation using laparoscopy and ultrasound guidance. And I'll also talk about why we are talking about microwave ablation amongst all the other various methods of treating adenomyosis. I have no conflicts of interest. So let me directly jump into the topic that adenomyosis and its management is actually a headache for us gynecologists, and it's a difficult task to always treat adenomyosis, whether it is medical management or whether it is surgical management. And to talk about the problems with medical management, the problems are very obvious. The success rate are not as great. There is, and after the patients, even if they get some success, the compliance is an issue. And once they stop the treatment, there is a rebound disease. And with the surgical management, we already saw a very good talk on endometriosis surgery by Smeet, and he also spoke briefly about adenomyosis. With surgical management, we know that it requires a very high degree of surgical expertise. So a limited number of people get trained to reach in that level of surgical expertise to manage it laparoscopically. And even if you do manage it surgically, with laparoscopy or even with open surgery, the problem of residual disease still exists because the adenomyosis is a disease which does not have very clear margins. So, and even if you do a very good job surgically, the post-operative healing is not completely in your hands, and that is the reason why we see certain complications. So when we talk about medical management, are we under-treating adenomyosis? Probably. And when we talk about surgical management, are we over-treating adenomyosis in some patients? Maybe. So we definitely need something more, and a middle way in between these two extremes. Probably ablation techniques could fill this gap. Now, ablation techniques are not new. So I'm not talking about something very new, but use of energies, various kind of energies in ablation, there have been few updates. We all have been aware of high intensity focused ultrasound, which was introduced about a decade back. Then came the radio frequency ablation, which has its own limitation. Today's topic, I'm not going to talk about radio frequency because it's a big topic in itself. I will speak about microwave, which is also a thermal ablation technique. But there are certain non-thermal ablation techniques also which will be upcoming in the future. And to briefly talk about them, there is something known as non-thermal irreversible electroporation. This sounds very complex, but I'll tell you very briefly what it is. You have to insert 2 electrodes around a particular tumor or a lesion which you want to ablate. And a special kind of a current is passed between these 2 electrodes, which creates pores into the cell membrane of the diseased tissue. And therefore, it kills that tissue without increasing the tissue temperature. So that is a non-thermal way, but it is still in the experimental stage and not yet available. But what I'm going to talk about is the microwave ablation, which is a new micro-invasive adenomyosis treatment methodology. But before jumping into the topic, let's talk briefly about the physics of microwave. We all use microwave every day in our household kitchens, and but we know that microwave works in heating food very well, especially the foodstuffs which contain water. So this brings us to the physics of microwave. Microwave is a kind of electromagnetic radiation which has frequency of about 1 gigahertz to 1000 gigahertz. And it basically interacts with water molecule by when the microwave passes through the tissue that contains water, it flips the charge about 2 to 5 billion times. And this high frequency of flipping the charge flips the water molecule, which is a bipolar molecule. And this flipping of water molecules causes friction and rise of temperature up to 200 degrees Celsius. So that is how microwave works. Okay. So it is, mind you, a very, very powerful, probably one of the most powerful energy device that we will encounter in gynecology. So this is the microwave generator which I use, and the antenna which is used for gynecological purposes, antenna of the needle, is about 15 gauge, that is 1.8 millimeter, very small needle, and about 200 millimeters in its length. Now the microwave ablation over the last 6 to 7 years has itself undergone a lot of progress, and the antennas today and the ablation techniques today give us a nearly spherical zone of ablation, so that when you are ablating, you can be assured that the effect of ablation is going to be more or less circular. So this is very important because that is how you are going to calculate that for your operative planning, you can measure the size of the fibroid or adenomyosis disease and accordingly select the protocol. This is another video that shows you how powerful microwave is. That is an antenna soaked in the bath of egg yolk, and you can see within a matter of seconds, it can denaturate the proteins, and you can see the egg white. Okay, so the ablation zones have been studied ex vivo mainly, and that is how they have calculated the nearly spherical zones. And we can know by preoperative planning that for this size of adenomyosis lesion, what is the kind of protocol I'm going to use, what is the energy setting I'm going to use, and what is the duration of energy that you are going to deliver. But at the same time, intraoperative monitoring with ultrasonography is equally important, because that will be your ultimate guide to what is happening inside. And because this topic is very new to everyone, I'll show you a short animation of how the procedure goes. Let's look at it.
be at risk for uterine fibroids or adenomyosis. There are 3 types of uterine fibroids, categorized by their location: intramural fibroids, submucosal fibroids, and subserosal fibroids. Adenomyosis is another common disorder that affects women of all age groups. Don't worry, you can now treat them with minimally invasive microwave ablation thermal therapy, also known as MWA. It is a uterus-conserving technique. With this tiny microwave ablation antenna, to kill only the fibroid or adenomyosis without injuring healthy tissue. MWA fibroids or adenomyosis can be performed by abdominal approach. It is a safe treatment which is guided by ultrasound image throughout the procedure, ensuring precise insertion of the MWA antenna into the targeted area. MWA uses heat to kill and necrotize the fibroid tissue and shrink the fibroid without cutting or removing the uterus. It is a very fast procedure, which can be completed in about 15 minutes. The residual fibroids will continue to shrink and completely absorbed by our body eventually. Most importantly, your uterus remains intact with virtually no scarring left on your stomach. MWA can also be treated by vaginal approach. MWA antenna comes with a smart cooling system internally to prevent the risk of overheating or damage to normal tissue. The whole procedure will be precisely monitored by ultrasound image. A tiny MWA antenna of 1.6 millimeters is inserted into the fibroids. Activation of microwave energy will heat up the tissue in the fibroids, causing the fibroids tissue to die, leading to shrinkage of the fibroids without removing them. MWA is able to treat multiple fibroids simultaneously. The treated fibroids do not require any removal or cutting. They will shrink as the body absorbs the ablated tissue over time. It helps to regain a functional and healthy uterus. Treat fibroids or at.
So we did the first microwave ablation dating back in 2021 for fibroids and adenomyosis. And I'll show you a short video of how that goes. The procedure, which I'm showing you a video, externally shot video, so that because it uses laparoscopy and ultrasonography both. So the coordination between both the technologies should be in tandem to for the smooth procedure. So as I showed you earlier, that is the microwave generator and the antenna which we are using. And this patient is having diffuse adenomyosis, both in anterior walls and posterior wall. So for diffuse adenomyosis, we are going to use a different way of using the microwave ablation. What we have in the uterus is a manipulator. And through that manipulator, we are running a normal saline fluid continuously. So that gives us a very good contrast, and we can visualize the endometrial cavity very well. This is how we set the protocol on the microwave generator, which has been calculated according to preoperative ultrasonography. And we put in a 5 millimeter laparoscope through the umbilicus. And while doing transabdominal USG, we then place a microwave antenna. As I told you, it is just 1.8 millimeters. So all it requires is a small nick. And then we visualize the antenna laparoscopically, and then it is passed into the substance of the uterus. Now, once the antenna passes in the substance of uterus, it will be further visualized again in the transabdominal ultrasonography. Now, because this is a low pressure laparoscopy, the uterus has been acutely anteverted, and therefore we can visualize the uterus and the uterine walls through transabdominal sonography. And you can see the antenna passing through the posterior wall of the uterus. And then we begin the ablation. The ablation is visualized in the ultrasonography by seeing the hyperechoic bubbles which are generated as the temperature rises within the tissue. So you have to be very careful that the bubbles and the hyperechogenic zone or the ablation zone stays within the lesion and barely reaches the serosa and the endometrium, especially if the lesion or the adenomyosis is not involving the junctional zone. If it is involving the junctional zone, you can just stay up to the endometrium, but not beyond. So it is recommended to have ablation zone up to the 70% of the lesion, between 70 to 80% of the lesion. And then we insert the antenna into the anterior wall because this is a diffuse adenomyosis. The anterior myometrium also has significant adenomyosis. But if the lesion is not very large, what you have to use is known as moving shot technique. That is, you deliver the energy for short bursts for 5 to 10 seconds. And as you see the bubbles being generated, you're visualizing the echoes in the ultrasonography. You keep withdrawing the antenna every 10 seconds. And you can see the endometrial cavity very well because of a continuous saline irrigation transvaginally. And once the ablation zone of the entire lesion has been visualized, that is the time to terminate the procedure. Post-operatively, you can confirm this by Doppler that you have ablated the lesion or by contrast-enhanced ultrasonography. So the most important question is how much to ablate. Because this is a very powerful tool, you can easily cause damage to the myometrium and the surrounding viscera as well, if you are not careful. So you have to very carefully plan during the preoperative ultrasonography or MRI that what is the size of your lesion, and you have to mark your lesion before you start ablation. And your ablation, for effective ablation, it should exceed 70% and should not surpass more than 90% lesion. So you are not targeting the 100% ablation of the lesion. Because of the thermal lateral spread, you will be damaging the surrounding myometrium as well. And here's another procedure which we did just last month. This was focal adenomyosis in the posterior wall, and you can see the echogenic ablation zone being created on ultrasonography. I do all my procedures under laparoscopy guidance, as I want to be very sure that all the viscera is away from the arms of thermal damage. And as I told you, intraoperatively, you can use the SonoView dye to visualize using the contrast that the ablation zone is complete. The ablated zone will not show the contrast being filled. So this is a very interesting case which I observed in China at the place of Dr. Xiaoming Gong, who has been my teacher for microablation. And this was the case which I had observed with a large focal adenomyoma of 7 by 9 centimeters. And immediately post-operatively, when I saw the patient after 2 weeks, the size had already started to reduce on the post-operative MRI, follow-up MRI. So how do we follow up the microwave ablated patients, and what are the results, and what are the symptom reliefs? Because basically this is a conservative procedure which we are doing to conserve the uterus and to reduce the symptoms of the patient. So it has, I will quote here this systematic review, which has looked over ultrasound-guided percutaneous microwave ablation for a wide population of patients. The ablation rate that was observed was about 80 to 91%, and the volume reduction of the uterus, entire uterus, was 55 to 64%, and the lesion, that is the nidus volume reduction, was 64 to 93%. This is after 12 months of follow-up. So mind you that the duration to reduce these symptoms is also significant after microablation. Do not expect an immediate relief. And same goes with the symptomatic relief. We are never talking about 100% relief. We are trying to reduce the symptoms of the patient in the want, in the desire to conserve the uterus or to avoid a surgical procedure. And that symptom relief is going to take some time. So it has also been observed and seen that ultrasound-guided percutaneous microwave ablation does not have any reduction in the ovarian function. But as of now, the evidence for use of microwave ablation in fertility enhancing procedure, that is for treating the adenomyosis for fertility enhancement, is not there. There are only anecdotal reports of post-ablation patients becoming pregnant and delivering normally. I have also myself had a patient for fibroid ablation. Patient was not initially desirous of fertility, but after treatment, after 8 months, when I told her that the fibroid size has reduced by 60%, the patient conceived, and then we observed the pregnancy very closely, and she had delivered normally. But these are only anecdotal reports, and there are no definitive guidelines on fertility treatment. So we are only talking about patients with menstrual disorders, with adenomyosis or fibroids, and treating them with microwave ablation. So it is very important whenever we talk about any new procedure or a technique to discuss about the complications. The commonest complications after this procedure are some pain, but this pain is not significant pain. I don't have a very wide experience. I don't consider myself an expert on this topic. I have done only 26 microwave ablation as of now, but none of the patients have complained of severe pain. You can manage by simple NSAIDs, and the pain lasts at least at the max for 2 to 3 days. The commonest complaint has been the vaginal discharge, which is up to 7 to 88% of the women will have vaginal discharge after microwave ablation, because probably as the tissue gets ablated and it still remains as a solid tissue, but because it is necrotic, the fluid is shed from the tissue, and that fluid probably finds the easiest route out of the body, that is transvaginal. So you have to take care, give a good antibiotic coverage, and probably that is the reason that some patients will have fever and infection, but the rate of infection and the fever is not very high. The commonest side effect which you can say is vaginal discharge. And there have been reports of thermal damage, especially with percutaneous ultrasound-guided microwave ablation without any control of laparoscopy. There have been instances where bowel injury and bladder injury has occurred. So who is the ideal patient for this kind of a therapy? Right now, as far as I understand and whatever I have studied, I think a patient who has a poor response to medical therapy, who has a big lesion or a big disease, big volume of adenomyosis, has no desire for future fertility, and does not want hysterectomy, which is the definitive treatment for adenomyosis. As I discussed earlier, that after microwave ablation, the results take time, and also they may not be 100%. So therefore, it is a very good idea to combine this with the medical management, and the upcoming data in the future research also, or the ongoing trials, and from the experts in the field with whom I'm in communication with, it is generally understood amongst experts that microwave ablation plus medical management with either Denogest or levonorgestrel intrauterine device is the best way to go ahead and manage such patients for the most effective results. So in conclusion, laparoscopic and USG guided microwave ablation appears a feasible new non-surgical way of treating adenomyosis in an attempt to save the uterus. And I think this becomes even more relevant as recently Honorable Supreme Court of India had given a directive to states to come up with guidelines to reduce the hysterectomies in less than 40 years of age group. So I see this as a potential technique or technology in that regard. Thank you so much.
Excellent presentation, Dr. Suyash. May I request the chairpersons to kindly give their valuable comments on this, please?
Yeah. Hello. Thank you, Dr. Naval. It was a wonderful presentation of a very new modality of treatment of adenomyosis. I wanted to ask one question, whether this period of ablation, like the effect starts coming after, a few weeks to few months, but then how long the effect would last? Would it be like, is it likely to recur after some time? What are the reports of, what is the study which says about the duration of remission of symptoms?
Yeah, thank you for I think it's a very, very pertinent and a relevant question, ma'am. See, as I told you during the presentation, that we are not treating the 100% disease. So obviously there is a risk of recurrence. Now, to know that how much that recurrence risk is there depends on the ablation how much ablation was done in the first place. As studies have classified that less than 70% ablation is the failure of surgeon to do effective ablation. So it should be more than 70%. That is the first thing. But it should not be 100%. And secondly, we don't have any randomized control trials that talk about that or that discuss or that have given us the results in terms of what is the exact recurrence of this technique. As I think this technique is relatively new, I think we'll have to wait for these answers, but definitely we have to tell every patient who consents for this that there is a risk of recurrence and this is not a definitive management. This is a conservative, supportive management.
Also, I wanted to just ask, of course, taking guidance of laparoscopy and ultrasound together gives a lot of safety, but is it required for all patients or only for patients where adhesions are expected, like previous cesarean or endometriosis known patient and all that? Because it, definitely gives the risk of anesthesia and all that, no? So once we have to do laparoscopy, of course.
Yeah, ma'am. I understand the idea of only doing is tempting, but the benefit of laparoscopy is one is safety. Second is many a times we have undiagnosed endometriosis, which we can find. So this also serves as a diagnostic laparoscopy.
That's right.
And secondly, especially if your lesion is very close to serosa and your ablation zone is going to go close to serosa, so it would be better to put in a laparoscope to visualize that.
Right, right.
Yeah.
Hi, Dr.
You can
Suresh.
completely do only only ultrasound guided also. That is how most of the interventional radiologists are doing it. But I think in the hands of gynecologists who also are very well versed with laparoscopy, it's a very good idea to put in laparoscope as well.
Yeah.
Hello.
Dr.
Yeah. Dr. Suresh, it was a very nice presentation on a very new topic. And you have shown the video, cleared quite a lot of concepts, but there are also few questions in my mind. So you were talking most of the time for adenomyosis. So what is the current status for fibroids? So you are trying in some patient, as I have heard in your lectures. So what is the current status for fibroid?
Yeah, the energy and the technology is same for the fibroid, right? Well, the topic was adenomyosis. That's why I spoke only about the adenomyosis. It can be used for fibroids also. See, for the microwave ablation right now, the upper limit is 8 centimeters of fibroid, as is recommended in most of the literature. Okay, so the case selection has to be very important. And I told you that for fertility enhancement, we don't have any evidence. So if you have a case where a patient does not want a surgical treatment or is unfit for it's basically about the desire of the patient who does not want to undergo myomectomy. Only then you would choose it for microablation, I guess. But for adenomyosis, I like this. I prefer this modality more than the surgical management. It is my personal preference because I'm not particularly happy with the laparoscopic management of adenomyosis myself as a technique in itself. So it is just my personal preference. But for fibroids, I have had very few patients because I think laparoscopic myomectomy is such a straightforward surgery. Only if the patient strongly desires to not undergo such a surgical management. Only then I think makes sense.
But sometimes the patient is like beyond 40 years and there are multiple fibroids, and to avoid hysterectomy.
For multiple fibroids, maybe as a combination treatment, maybe you remove just only the bigger fibroids and the medium-sized fibroids. So see, there are no clear guidelines on this. This is a newer modality, but I think there is a subset of patients which would want this and for which this can be employed, where we are skeptical about doing an extensive surgery or patient does not want it, something like that.
Yeah. Thank
I
you.
don't know. I would like to know the expert's opinion that where we can use this technology best. I found personally for adenomyosis, this is a great modality.
Right. A great talk, as it was always nice to hear you.
Yeah.
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 Thank you, Dr. Meenakshi, Dr. Suyash. Always great to listen to you. Can I just invite Dr. Bhaskar Pal, sir? He is actually flying all across the country, and please do enlighten us and give us a few comments. Bhaskar Pal, sir, is especially involved in this webinar because he is FOGSI representative to SAFOG, and of course, he has a love for endoscopy. So these two link together. And sir, are you there?
Yeah, I'm there. Thank you very much for inviting me. And it's great to be in the company. I'm very sorry that I am actually on my way to Amravati from Nagpur, and my flight from Delhi was delayed. So I'm right now in the car, and it's great to be in the company of people like Asha and Narendra. I can see Asha has joined and Narendra must have left. Well done, Dr. Gaurav Desai, Dr. Aarti Chitkara. Thank you for inviting me. And so too, Dr. Apurva Datta, Dr. Supriya Jaiswal. And I think there are 6 brilliant speakers. And I think endoscopy is a topic close to my heart because it is just not good enough showing great endoscopic surgeries to people that I can do it. I think what is important is how we can make it accessible, reproducible, and economically feasible for the women of our country to go ahead. And I think that is one of the reasons and one of the ways we need to propagate endoscopy, how we can offer it to every woman in our country so we can build up the capacity. We make teaching available, we make it easier, and just not showing how difficult things can be done. So I think the topics have been chosen very well, right, starting from safety and great speakers, great young speakers. Munjal Pandya, Amogh Chimote, Surakshit Battina, Smeet Patel, Suyash. I wouldn't put Suyash in the category of the young, and Santwan Mehta, and very senior and experienced chairpersons. We have Dr. Nisha Kapoor and Dr. Meenakshi Goel, great endoscopic surgeons here. I don't see Anupama. And we also have Dr. Jyoti Malik, Dr. Aruna Soman, Dr. Supriya Jaiswal, Dr. Ramani Devi, the young Dr. Isha Kriplani, Dr. Archana Kumari, Dr. Radha Lakshmi, and Dr. Ritika Agarwal. I would actually take this opportunity to comment on Shuash's talk. I think Dr. Meenakshi raised a very pertinent question. I think Shuash actually answered that beautifully, and that would be my take also. I think as a laparoscopic surgeon, a myomectomy is a very rewarding surgery. And there are several options available, like a uterine artery ablation, MRI-guided focused ultrasound therapy. But we all know that with those therapies, the reoperation rate within 5 years is very high. In different studies, it ranges from 60 to 90%. So I actually do not get enthused by these conservative, less invasive procedures when it comes to fibroid. But when it comes to adenomyosis, I think none of us laparoscopic surgeons enjoy operating on adenomyosis because it is always a surgery where we are compromising, we cannot eradicate the disease. And so that is where I think these people have looked at uterine artery ablation in global adenomyosis as well. And that is where we need to, this holds promise. And I think the point is also right that if we want to add a laparoscopy, and especially if you're working in a corporate hospital, that would add to the cost enormously. But when you're doing it in your own setup, I'm sure you can control the cost. At the initial days, I think to make sure safety is important. After you do 50, 100 cases where you put the laparoscope, you possibly, I'm sure, you might be in a position to say, yes, we do not need the laparoscopy. But I think it is safety first when you are developing a technology and trying out a technology. So Meenakshi, I would agree with Suyash that I will not be particularly interested in this, in the application of this in fibroids, because I don't think the results will be much different from uterine artery embolization or a focused ultrasound therapy. But I would be keenly watching what happens in adenomyosis, because I think that is where the surgery is suboptimal. Thank you for having me, Gaurav, and I wish you all the best.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Aarti, can we have Dr. Asha Bakshi, Madam, CV?
Sure.
I think, Madam, it was a good that you joined at this time, because there is, of course, as Dr. Suyash said, there is that whole gray area of whether this can be used in adolescents and regarding fertility. Madam is, of course, the Honorary Secretary of ISAR for assisted reproduction. And I mean, I could go on and on. She's received so many awards like Kumud Tamaskar Award, has organized so many workshops, conferences. Some of them I've been a part of. So I think, Madam, if you could just say a few words and give your comments on this talk by Dr. Suyash.
Thank you so much, Gaurav, for inviting me. And it's indeed nice to see that all the organizations, SAFOG-ISAR and FOGSI have come together. And you have really made a very good program by including such good topics. And laparoscopy is really close to my heart, and it means I've been the ones who have been one of the, laparoscopic surgeons in 1994 when the thing started. So, and I love laparoscopy, and now I know that you younger generation are equipped with such good equipment. And today it was really nice to listen to Suyash's talk on use of microwave ablation for adenomyosis. And it's really interesting because adenomyosis is a nuisance for all of us infertility specialists also. But at the moment, though they have not recommended it much for fertility enhancement, but maybe if more cases are reported, then it would be worth trying this for fertility also. But I'm sure at the moment it is not recommended. But it was interesting to hear that he had a patient who delivered after the microwave ablation. So, because usually whenever we all know that adenomyoma, it, grows by replacing the myometrium. And more you excise, actually you are excising the myometrium, and the functional myometrium gets less and less. And always you are scared that maybe in future there would be chances of rupture. And maybe something as simple as microwave seems to be very interesting. Hopefully the complications are less, and when you're being so safe using it under ultrasound guidance, at the same time laparoscopy guidance, the complications are going to be very less. So overall, it has been a very good talk, and I'm sure with time to come it will get popular. And these type of webinars are really, really important because whatever said and done, still laparoscopy and hysteroscopy is limited to only few gynecologists. So this is something I think people have to learn and develop the technique, and it should spread to all the gynecologists. And though for certain procedures require expertise, and for that you really need, but at least sensitization is very important in which technique to be used for which patient. So very interesting, and all the best for your, Gaurav, all the best for your upcoming elections. And it was nice to hear Bhaskar Pal, who is a close friend, and I wish him good luck as well. And I'm happy that all the committees of FOGSI have come together to do this webinar. Apurva and Supriya and all have come together. And thank you, Aarti, for inviting me and conducting the program so well. So all the best, and I think you should get going with your program. Less interruptions.
Thank you, Madam. Thank you for your time.
Thank you, ma'am. Thank you for joining in, ma'am. Dr. Suyash, I have one question. Sorry, I'm interrupting here. Are there any studies where we have any comparison or RCTs which compare adenomyomectomy versus microwave ablation and the obstetric outcomes, like outcomes of rupture or placenta creta spectrum? So are there any studies currently on that?
No, the RCTs are ongoing. The one RCT about adenomyosis and one about fibroid, and comparing it with the laparoscopic management is undergoing. But I don't know if they are following up the patient up to the level of whether the patient develops placenta accreta or not. I don't know the details of the.
No, I'm sure, Shwes, that will not be possible. It's impossible in an RCT. You can compare it with medical management. You can compare it with surgical management. But I think it is too resource intensive to follow up a patient for 10 years. Means you'll have to essentially depend on prospective data, like a registry data, like we know we had any worries about IUGR and uterine artery embolization. And when we followed up the patients, we saw the incidence of IUGR or miscarriage was not increased. So we'll have to depend on that. I don't expect a randomized control trial be able to follow up patients into the pregnancy.
Yeah, I completely agree with you, sir, and even your perspective, what you said about fibroids, and yeah, I see the potential for this technology being used in for adenomyosis and hopefully in future for fertility as well. Thank you.
Thank you, sir, for that reply. Moving ahead, can we go ahead with the next talk? I think everybody was very mesmerized by Dr. Subhash Naval sir's talk. Thank you, sir. It was very informative. Now, may I invite our next speaker, Dr. Santwan Mehta, sir. This is the last talk for the day, where he'll be talking about salpingoscopy and whether is it relevant in today's era of ART. May I request Dr. Gaurav Desai, sir, to introduce and welcome the chairpersons, please.
Yeah, can you share the slides, Arti?
Yeah.
So, I mean, it's, of course, always a pleasure to introduce a good friend and someone's work who I've admired, Dr. Santwan Mehta. He's an up-and-coming endoscopist from Ahmedabad, and he's of course always involved in some of these workshops. And he's even come for the SAFOG workshop in Mumbai when we had it. So that was the connection between this SAFOG-FOGSI-ISAR thing. And of course, Suyansh is talking on salpingoscopy, which is relevant with fertility, relevant with reproductive medicine. So all these sort of, I mean, everyone involved is sort of a jigsaw, pieces of a jigsaw. And Arti, can you just share the CVs, please?
Yeah.
I'd of course like to invite Dr. Jyoti Malik, madam. She's of course a really renowned gynecologist in Arti.
In Haryana, yeah.
In Bahadurgarh,
In Bahadurgarh, Haryana.
Thank you so much. Thank you, Dr. Gaurav. I think I don't need any introductions.
Absolutely,
Actually, it has been amazing, the program that you have set in. Let me really, really congratulate you. You've done a fabulous job. And thank you so much, Dr. Aarti. You have really, I mean, I would thank you for inviting me, because I thought I'll just go for my session. I'll chair my session at 8:30, and that's the end of it. But I don't know why I just switched on right from 6 o'clock and I could not stop.
Yeah.
And I heard each one very, very sincerely, and every speaker was perfect, very new, very to the point, very pertinent, absolutely amazing. So the last speaker I'm going to, is going to be too good as well, I'm sure. So we'll just listen to Dr. Mehta.
Madam, I just want to also introduce Aarti as a chairperson.
Yeah, Aarti.
I was so happy with her being the master of ceremonies. I said I have to give her a chair post. She deserves, a chair
I was
post.
not expecting. I was just trying to hide my slide anyways. Yes, Dr. Gaurav.
No. I admire even my master of ceremonies. So they are really teach me also. And I think you all will do justice to Santwan, because you all will be the correct people for his talk. So Santwan, the stage is yours.
Oh, thank you very much, Gaurav bhai. It is indeed a big honor for me to share my work with the dignitaries of our entire country, Bhaskar Pal sir, Asha madam, Narendra sir, and to my chairperson. So today I'm just sharing my screen. Aarti madam, can you please allow me to share the screen?
Yes, sir, just doing that.
Okay. Okay, so I hope you can visualize my screen, right? Okay, so it is indeed an honor. Gaurav bhai, thank you very much. So today my topic of discussion is salpingoscopy. Is it still relevant in today's era of ART? So we all are very much happy doing the diagnostic hysterolaparoscopy. Like it is the commonest fertility enhancing procedure. We all do this and we try to locate the mechanical factor in the infertility and try to correct it. But we seldom do the salpingoscopy. The major reason for that is the number of ART, IVF is being done in recent years in recently. So like we touched around 2 to 2.5 lakhs of cycles in 2020, and it is expected to be 5 to 6 lakhs of the cycle per year in 2030. But I'm sure you all will be you all agree with me that even after the IVF, there are so many dropout rates. Number one reason in our country, because of thanks to this studies, I found out that number one reason for the dropout is the financial burden, that many of the people are not able to uh, have enough money support for the IVF. And second, another important factor for the dropout is the psychological stress. Many of the things would say that I'm sure many of the you will agree with me that there are many patients who are young, like 28, 29 years of the age, and they are not having any problems, like their tubes are fine, AMH is good, husband semen analysis are fine, even they have gone for the IUI, laparoscopy is also normal, then we consider them as an unexplained infertility. Now to explain them to go for the IVF, it becomes very difficult. So in my view, I feel salpingoscopy is a very important subject because here we are doing the detailed assessment of the interior part of the ampullary tube. Actually, ampullary part is the tube where the fertilization is going to happen. So we often forget that the tubal are the as much as 35% of the cause factor for the infertility. And these tubes are not just a passive conduit. Like if we do the HSG or SSG, we may find out there is a passage of the fluid and we feel the tubes are open, but tubes plays an important part in other important things like the fertilization, the sperm capacitation, embryo storage. And all these things are only possible if the tubes are physiologically normal also. I'm going to show you the salpingoscopy entire procedure, its importance, and how do we interpret that. And by the end of my presentation, you will also agree with me. So we do have lots of paper also that salpingoscopy and laparoscopy is kind of complement each other for the prediction of the fertility. So how do we do that? We basically use the Bitochi hysteroscope. So the entire assembly would be somewhere around 2.9 mm, and we introduce it to the suprapubic port. So like as in all cases of the diagnostic hysteroscopy, like we go inside, we put the umbilical port and we check for the adnexal structure. As you can see over here, both the tubes are absolutely fine, normal, no additions, nothing like that. Then obviously we ask our assistant to push the dye from below, and we are happy to see the free spillage of the dye. And we usually stop our procedure at this moment. I would like all of you to go furthermore. Like now, when we are doing the salpingoscopy, like we introduce the salpingoscope, that is a Bitochi hysteroscope, from the middle port, suprapubic port, and we with the normal saline, the entire tube will be distended, and we try to identify the architecture inside the tube, and we go at least up to the ampullary end. Now, what we need to see in the salpingoscopy. So, as you can see, there are major folds which can be seen. So there are two types of things we need to see. Number one is the major folds, and all those things which you are able to see, these are the primary and major folds, and in between the major fold, you will see the minor and secondary fold. So if a tube needs to have a proper function, these folds have to be very much delineated. There should be properly demarcated. There should not be any flattening, or there should not be any adhesions in between. So how do we interpret the findings of the salpingoscopy? So these two gentlemen, Brosnan and Puteman, have put up this classification very well in advance, somewhere between 1995 to 2000. So from grade 1 is the normal, and grade 5 is complete loss of and abnormal tubes. I'll show you the videos pertaining to the each and every slide, each and every grade, so it becomes more clearer to you. So this is grade 1. These are normal, healthy looking mucosal folds. As you can see over here, the primary folds are very well demarcated. They are not flattened out. So we expect them to work efficiently. At the same time, the secondary folds are also very well clear, demarcated areas. Okay, so they help in the proper ciliary movements, which are necessary for the transportation of the gametes. So this is absolutely fine, grade 1 normal looking tubes. In grade 2, we may see minimal flattening of the primary as well as the secondary folds. As you can see here, the primary folds are good, but you will not see the proper delineation of the secondary folds. And even there is contact microscopy, meaning that this nucleus has stained that methylene blue. It means that there is little less movement of less ciliary movements. Okay, so these are the grade 2 salpingoscopic findings. The grade 3 is again, now there will be more flattening and some kind of additions you will be able to find out. So you can see this, all this area, there are no clear demarcation of the primary or the secondary folds, and again you will see a little bit of synechias are there and adhesions are there. So these tubes have lost their physiological functional way. Now grade 4, see, these are mere pipes only. Okay, so there are no physiological function left in such tubes. So you will definitely find a spillage of the dye, but basically they are not capable of doing the normal physiological function. Some cases when you find such kind of adhesions, these are also grade 4 types of the tubes. And grade 5, there is complete adhesions. You may see some kind of lacunae. So, if you ask your assistant to push the dye from below, you may find the spillage is there. But these tubes are not good for conducting their purpose. Okay, so basically these are severe adhesions are there, and there is no primary secondary folds. You cannot conclude anything out of this tube. So these are severely damaged tubes. Even if they are externally looking normal, they are not physiologically normal tubes. I would also like to say the salpingoscopy finding in special cases, like in tuberculosis. Sometimes in tuberculosis, you may find completely normal tubes from the outside. But if you do the salpingoscopy, you can see normal tube, no problem from the outside. Even there is a spillage is also there. But in salpingoscopy, you may find some tubercles inside. So this is definitely a damaged tube. It's less likely to give you the pregnancy. In fact, there are chances that ectopic pregnancy can also occur in such kind of tubes. Even with the things at the hydrosalpinx, like if you find out, see, this is the case where the hydrosalpinx is there. So in normal cases, what we try to do is like we try to find out the fimbria and we try to evert them out, and we try to establish the passage. So as you can see over here that fimbria have been everted out, and we are trying to fix it by applying the bipolar. So we did the fimbrioblastin and we feel happy that we have established the passage. But we must do the salpingoscopy in such cases so that we find out whether is this tube is good to do the capable of doing pregnancy or not. So as you can see, there are various grades of adhesions. Even the primary and secondary folds are not properly developed. So this tubes is of no use. Usually we take the consent for the, in such cases, when we go for the hydrosalpinx correction, we take for the salpingectomy consent. It's better to get rid of these tubes rather than going for the any major ectopic pregnancy or any difficulty. So now we'll just have a look about the literature, what literature has to say about this. The two gentlemen, Brosnan and Putman, who had put up the classification, they studied 158 patients. According to them, grade 1 and grade 2 have the highest chances of cumulative pregnancy rate of 71%. And as the grade increases, meaning the tubes are being abnormal, so there are less chances of cumulative pregnancy rate. Even this is a very wonderful paper where they had examined the external appearance of the tube with the internal appearance, and then they have found out that about 25.8% of normal looking tubes at the laparoscopy had mucosal lesions in the salpingoscopy. So this study again confirms that the tubes that look normal externally can have lesions inside the endosalpinx. This is also a good Japanese studies, like they have devised the F score, means the fertility score. They take care of this they examine the inside of the tube salpingoscopically, and they see if any of this thing is there. They put a score. Lesser the score, higher the chances of the infertility. Lesser the score, higher the chances of the fertility. Our data at Mayflower, like we have studied around 3,946 patients over the 10 years with the salpingoscopy. We here perform salpingoscopy in each and every cases that matches with the Brosnan-Putman classification, that as the grade increases, there are lesser chances of the normal cumulative pregnancy rates and higher chances of the ectopic pregnancy. So to conclude, we would definitely say that salpingoscopy has a definitive prognostic and predictive value, especially in case of the unexplained infertility, where you can explain the patient in a more better way that there are chances why she is not getting pregnant. Just mere passage of the dye through the tube is not necessary to get the pregnancy. Even we can reduce the chances of the ectopic pregnancy also if we identify the damaged tube at the proper time. So salpingoscopy complements diagnostic laparoscopy, and it should be a part of assessment for the infertile patients. Thank you very much.
Thank you so much. Thank you, Dr. Mehta. That was wonderful. Actually, it is a food for thought. Normally, we all just do a diagnostic laparoscopy, hysteroscopy, and we think it is the end of it. But I think it is a good way of explaining the unexplained infertility, because we just say everything is fine and still you're not able to conceive. So we have this, by doing this, we document that the tubes are functional. I mean, it is not that the tubes are patent, they have to be functional to
Exactly,
be
to get the result.
For conception. So it is like explaining that, and definitely if they are not functional, we rather than waiting, we might as well hurry up this patient for ART. So this, I mean, that waiting time, I mean, we can sort of counsel the patient for a early ART treatment.
Exactly.
Yeah,
Exactly.
so very nice. Very
Thank you,
nice.
Thank you, ma'am.
I think we should also start doing that.
Yes, ma'am.
Excellent talk, Dr. Mehta. So it was very informative and actually an eye-opener to all of us. We sometimes just looking at the structural, as ma'am has mentioned, looking at the structural aspect, we just go ahead with, doing salpingectomy or tubal clipping. So we should always assess the functional aspect, and it's really surprising. And somebody, our consultants, when they used to teach us in institute, they used to always say, there is nothing called as unexplained in medical sciences. There is
Exactly.
always a reason. You have to go.
There
Once
must be
you
some
want to
reason.
go and find out the reason, you'll always find out
You
the
will
reason.
find out.
So
Exactly.
yeah, it's very informative. Thank you, Dr. Mehta.
Thank you.
One
ma'am.
more
Thank you,
thing, should we do this methylene blue later on before performing a salpingoscopy? Because when we stain it with methylene blue, maybe we are not able to see the cilia so very nicely
Very
rather.
good.
So should
So,
we do
ma'am,
that
usually what we do is like normally, like we check the tubes externally. We do the methylene blue dye test, and then we go for the salpingoscopy. You are very right that sometimes if the methylene blue is so much in high concentration, you may find the false negative result. Like there is a uniform staining, generalized staining, which may hamper our actual findings of the salpings. But if we do the methylene blue titers, we are actually confirmed about the patency. So we can rule out there is no corneal block or something like that. So in a way, it's better to do the methylene blue dye test and then to go for a salpingoscopy.
Okay.
Yes, Santwan bhai, great talk. The last time you came to see me operate, at this time the stage was yours and you did absolutely 100%. So much so that even Amogh Chimote, who was talking much earlier, still stayed to listen to your talk. So that just
Pleasure. It's a
proves
pleasure.
that you did a great job. Amogh, any comments?
Yeah, so it actually is a good food for thought that salpingoscopy is something which can actually be looked into. Like Santwan bhai had mentioned that the physiological functionality of the tube if present. So just all other tests of tubal patency are not dynamic. They are just static. You are pushing the dye in pressure. May it be SSG, may it be HSG, may it be methylene blue. So that false sense of giving away of the tube because of the pressure, that will always be there. The dye will always come, but that does not mean that the tubes are
That does not
functional.
know. Exactly.
So
Exactly.
salpingoscopy, yes, you can actually find out if there are any lacunas or if there are any diverticulars, any adhesion somewhere. So a primitive form of this thing, what I do is do a bubble test, because
It's
if the
absolutely
tubes
fine.
are patent, the peritoneum has a negative pressure suction, so the bubbles are suctioned inside. The only thing that most of people don't do properly is that they don't close the fluid pressure.
Yes, yes.
The moment
yes,
you close
yes.
it, and if the tubes are patent, the bubbles are sucked inside very nicely. So this
Absolutely.
is something which can actually be explored in, and as and unexplained infertility because of a tube just
It's
having
not
a
the
spill but
physiological.
not having conception
Absolutely.
can be explained.
Absolutely, absolutely.
Superb top, Santwan bhai.
Thank you, Amogh bhai. I really appreciate, and your talk was also very fantastic. Thank you very much. Thank you very much, everyone. Thank you very much.
Thank you. Arti?
Yeah, moving ahead to the concluding part of this wonderfully organized webinar. First of all, I would like to thank Dr. Gaurav for, he's the master brain behind this wonderfully organized webinar. I would also like to take this opportunity to thank the SAFOG, FOGSI, and ISAR, all three coming together on one platform, and all the chairpersons and the speakers to take for taking out their valuable time. I would also like to thank Dr. Apurva, Dr. Supriya for contributing in this webinar with their societies as the chairpersons. Thank you, everybody. I would like to invite Dr. Gaurav to say a few words and conclude this webinar. Also, not to forget mentioning, thank you, Dr. Bhaskar Pal sir, for joining with your valuable time. I know sir has been really campaigning hard and running around everywhere. Thank you, sir, for your time and patience. And thank you, Dr. Narendra Malhotra, sir. Sir has already left, I think. And Dr. Madam. Sir is here. Dr. Bhaskar Pal, sir is here.
I said my pleasure. I just wanted to comment on Santwan's talk that Santan salpingoscopy is not new. His mentor has been talking about salpingoscopy for years. I think what the real reason salpingoscopy is not picked up is because widespread ability and gradually IVF becoming a little more and more active. So since that somebody on a previous topic or somebody who's got a fertility of a low threshold for moving on to IVF strategy. The role of salpingoscopy would be in which patient can delay the IVF. And I think the wide availability of IVF
I think the connection is a little poor.
Yeah, I think sir is traveling. Sir, your connection is a little unstable. We are not able to connect.
Because
Dr. Gaurav,
Okay.
can we
Yeah.
go ahead with concluding the webinar?
So, well, first of all, thank you everybody who joined. I think you all really made this webinar a success. I think there were continuously a good number of people who were there right from start to finish. And I think the success of a webinar is really when people listen right from the beginning to the end. Now, I'd of course like to acknowledge the dignitaries, the luminaries, Dr. Malhotra sir, Dr. Bhaskar Par sir, Dr. Asha Bakshi madam, the chairman of the two FOGSI committees who were there. And like I said, it's all about connecting dots. I mean, I have been, as some of you all might know, I've been attending these FOGSI conferences since I was a child. So, I mean, everything, the whole concept of at that time was how do we connect this such a diverse country and bring all the people's talents together. So, I mean, that was really the whole concept and the brain behind all this. So thank you to the chairpersons, the speakers. This stage was really yours and you all performed exceptionally well. Uh, I during this webinar, I've been planning for my next webinar. So I look for, I hope to see you all. It's an even better program. So looking forward to having you all there. I'd like to acknowledge, of course, Dr. Jaideep Tang, sir, who is the president of FOGSI. He couldn't be here, but he's, of course, always wishing me well. He was my MBBS teacher. So there's a lot I have learned from him. So thank you to him, as well as to FOGSI, which is the organization that really showcases our talent. So thank you all. And Aarti, just can you say your thanks and thank you also, Aarti, just letting you know. Thank you for putting your hard work in.
Thank you. I would not have much time to say. I think my baby is crying, so I'll have to
Yeah,
take.
I know. In spite of having a
Thank
baby.
you, Aarti. You were wonderful as a
Yeah.
coordinator. Thank you, Gaurav, for giving me the opportunity. It's nice to see you, Santwan.
Thank you to all the speakers. It was such an informative and really an eye-opener and food for thought. We've received such wonderful comments in the chat section for all the speakers. And thank you, Dr. Gaurav, for coming up with such an innovative idea. It was really a lot of hard work that you put in. Thank you, everybody. Thank you to all the chairpersons. Thank you, Nisha ma'am. Thank you, Jyoti ma'am. And as you've rightly said, people were actually there with us from the very beginning till the end, and they were like staying glued to the screens for such elaborate talks. Thank you all.
Thank you and good night, everyone.
Good night.